All right.
What you need to also do if somebody asks a question is
Repeat it.
because it's being recorded. Hear that? Everybody's got to repeat the question. I want to thank everybody for showing up. We're here for the student presentations, resident presentations, and this young man right here is distinguished trainee lecturer.
Thank you. My name is Ben. I'm a second-year med student at Arkansas College of Osteopathic Medicine. And what my project was, it was a retrospective review of bionic vision eligibility throughout the Henry Ford Health System. So I just want to give a shout out to Dr. Daniel Rathbun. He's not here, but he is my mentor for this project. And without him, it would not be able to be done. How do I progress slides?
Green button. Yeah, that clicker. Then you have the big green button.
That seems to be a laser pointer. Okay, perfect. So kind of a brief overview of what bionic vision is that it is a implant that you surgically implant either, there's two types, there's either a retinal implant or a cortical implant. So the retinal implants actually get implanted inside the eye on the retina, and it uses the retina's mechanisms to bring vision back, while the cortical implants, these are done via neurosurgery route, and these use the camera as actually pretty much a pseudo eye, and then that sends signals to the cortex, which then also brings some vision back as well. So on paper, the idea sounds really great, like to be able to bring vision back because of how many Americans suffer from blindness today. But it's something that I've never heard of, and I don't know if you guys have ever heard of it, but it's not really widespread used in the US and in the UK yet. So what me and Dr. Rathman wanted to do is figure out why exactly is this an issue, why is this device not used overall? So we wanted to tackle the eligibility to see if it was the eligibility, to see if not many patients would be eligible for these devices. So what we did is we picked 7 of the top devices that are being researched now, 3 cortical and 4 retinal. And what I did was I went throughout the whole Henry Ford patients, and we started off at about 17,000 patients. Then we wanted to whittle the numbers down a little bit. So what ICD-10 codes would these devices be able to treat? So those are retinizing pigmentosa, macular degeneration, geographic atrophy. So we applied all the ICD-10 codes and brings it down to about 6,500. Next thing we did is, out of those 6,500 patients, how many of those patients are functionally blind? And that brings it down to about 1,200. And then my job was to go manually into the rest of those 1,200 patients and see if they would be eligible for these devices. So things that I looked for was their optic nerve health, if they had any other retinal diseases that were excluded, if their age was too high or too low, and just if they were able to tolerate the surgery of the implantation. So what our data shows is that if you look at the graph on the right, you actually see a very stark difference between the cortical and the retinal devices, where the first 3 are the cortical devices, and the last 4 are going to be our retinal devices. So what that graph shows is that the retinal devices, there's a very high exclusion rate due to optic nerve disease such as glaucoma and other retinal conditions. While the cortical implants, those don't have as many exclusions. They really don't have any exclusions other than that the patient could not tolerate the surgery. Then if you look at the graph on the left, what that shows is that age was a very strong reason for patients to be excluded, where if they fell even 1 year out of the range, they're being excluded from these devices. So if we're able to work with these companies to combat that strict age cutoff, we would be able to increase eligibility by almost 30%. So the next question we wanted to ask is, where does that leave retinal implants? Because there's 98% are not eligible for these devices. So this right here is what patients with retinal implants see. So it's definitely not 20/20 vision. It's not even great vision, but I've read a few articles that the patients are just floored from being able to not see anything to be able to see lights and figure out something's in front of them. So it's very interesting. And that is kind of the vision that these retinal devices capture versus the cortical devices. Yes, they're more eligible where almost all patients can get them, but they describe that vision as a sort of starry sky appearance because it's hard to, when you're doing the surgery, to map out all of the visual cortex and have that perfect. While the retinal uses the actual retinal vision where you can actually move your eye and the camera moves with it. So it gives you a more natural feel versus the more abstract feel with the cortical devices. So that's all I have. Thank you.
Wow, short, sweet, nice. Okay, so we certainly have a few moments here for any questions. You know, I actually have an observation. So can you go back to the previous slide? So what you're saying is for mostly cortical view, it's the one on the right, or is it also retinal view would be the one on the right that people would see?
So the image on the right, what the patient sees, that's actually a retinal view. So it's definitely not great with how the technology is right now, but the cortical view is going to be more abstract. So essentially,
More abstract than that?
yeah. So essentially what happens is like if you put a white plate in front of a patient with the retinal device, they're able to see the edges of the white plate versus and they can even outline their own daughter's or mother's face. While with the cortical device, you almost just kind of see like a blur of just flashing lights. So you can tell something's in front of you, you just have no idea what it is. Yeah.
So, so is this only for people who are basically NLP in that eye from whatever disease, no light perception?
Yeah.
So they're totally blind?
Yep.
Because I was thinking, you know, I work with a large population of people who have Charles Bonnet syndrome. I don't know if you're familiar with that.
No.
It's medical. It's visual hallucinations for vision loss. And anytime you can improve their vision behind their particular threshold, that actually makes their hallucinations less common or go away. I've had some cataract surgeries, you know, with AMD, who, whatever that secret threshold was for that patient, I was able to eliminate the hallucinations. But it doesn't, I don't know if this is enough, you know, necessarily in those situations. Okay, any other questions? Well, thank you very much. That was very good. Thank you.
Thank you.
All right. Sarah, you're up. So what I'll ask for the speakers, just because again we have to vacate this room by 7, is if you're the next speaker after who's speaking, if during the question session, if you could already start working your way up so that we don't lose a minute. There's no minute to spare. You have 6 minutes. Okay. 2 minutes for questions after.
Excuse me. Okay, so my presentation was called Presenting Symptoms of Thyroid Eye Disease at a Single Center in South Florida, and it's a retrospective chart review.
And you're a resident.
Yes, I'm a PGY3 at Dr. Bach's program, Bayonet Point in Tampa. Okay, so the objective of this study was to characterize the presenting symptoms of patients diagnosed with thyroid eye disease at a single ophthalmology center in South Florida. And this was between the years of 2019, when the clinic opened, until January 2024, and compare the symptom distribution to previously reported patterns in the literature and kind of see whether they elected to undergo treatment with Tepezza and things like that. So thyroid eye disease, as we kind of all know, is also called Graves' orbitopathy and is an autoimmune inflammatory disorder affecting the orbit and periorbital tissues. Most commonly occurs in association with Graves' disease and results from immune-mediated inflammation of orbital fibroblasts, leading to expansion of extraocular muscles and orbital fat. The clinical manifestations of this disease include eyelid retraction, proptosis, diplopia, ocular irritation, periorbital edema, and then even things like globe subluxation, which is what happened with one of the patients in this study. TED is the most common cause of unilateral or bilateral proptosis in adults and may cause both cosmetic and visual impairment in severe cases. Treatment of thyroid eye disease varies based on disease severity and may include supportive care, immunosuppressive therapies like corticosteroids or Tepezza, orbital radiation and surgical interventions, including orbital decompression, and eyelid or strabismus surgery, depending on the symptoms. So for this study, it was a retrospective chart review. It was performed of all patients diagnosed with any thyroid eye disease at a single ophthalmology clinic in South Florida from July 2021 until January 2025. Over 4,900 patients were diagnosed with any thyroid-related diagnosis, but 37 patients actually had diagnosed thyroid eye disease. So a total of 37 patients were identified. The demographics were 33 of them, about 89% were female, and 4 were male, and then the age range was pretty large, from 7 to 84. And the presenting symptoms were dry eye, most commonly, and ocular surface irritation, and then proptosis or exophthalmos or globe subluxation in one of the patients. Diplopia was not quite as common, but even less than that was pain, lid abnormalities, and visual disturbance. So the study population demonstrated a strong female predominance, about 89%, which is consistent with the literature, and the reported epidemiologic patterns of TED that show that it's significantly higher in women. The most common presenting symptom included ocular surface irritation or dry eye, proptosis, and then diplopia. According to the literature, patients with mild disease may initially present with foreign body sensation, tearing, or photophobia secondary to exposure-related dry eye, while more advanced disease can present with pain, with eye movements, diplopia, proptosis, and extraocular muscle restriction. So we were really catching it in its early phases most commonly. In our cohort, 16 patients received Tepezza treatment. Other patients elected not to, whether they were too young, whether they were lost to follow-up, different things like that. Overall, the demographic characteristics and clinical presentations observed in our cohort aligned with previously reported features of thyroid eye disease. Our findings further highlight that ocular surface symptoms may present as a common early presentation, emphasizing the importance of considering TED in patients with any ocular irritation and a history of thyroiditis. So these findings highlight the importance of recognizing the varied presenting symptoms of thyroid eye disease, as early identification may allow for timely referral, appropriate monitoring, and earlier initiation of targeted therapies to prevent disease progression and vision-threatening complications. These are my references. Any questions? Most of them. So a lot of them came in because they were referred from endocrine, or they already had a diagnosis of thyroid abnormalities, and then they were just kind of worked up for thyroid eye disease, MRI, or, but most of them had a diagnosis of thyroiditis, and that was kind of the highest differential.
You said one had globe subluxation.
He didn't.
Do you recall? Yeah, she didn't. She did not. Okay. So it must not have been too severe.
Oh, it was completely subluxed the day before. They pushed it back in the ER and sent her to me.
Wow. Amazing. And that was my other question, and this is to the attendees in the audience. Who here has used or is using or plans to shortly use Tepezza? Anybody in their practice? Are you getting good results?
Yep. Good morning. I'm Brian Adams. I'm a PGY3 co-resident with Dr. Mustafa here out in Tampa Bay, Florida with Dr. Bach's program. So today I will be talking about an idea I came up with as a medical student. I spent a lot of time watching cataract surgery in my 3rd and 4th year, and I'd always heard about how difficult the capsulorhexis is to master. But there wasn't really a way for me to feel those mechanics, so this kind of came out of curiosity and a bit of creativity. I wanted to make something that could replicate that experience, and that's kind of what led to this project. So today I'll present a simple, low-cost model design to help trainees master continuous curvilinear capsulorhexis using a constrained closed chamber system. How do I go forward? The other green button. Sorry. All right. So capsulorhexis, as we know, is a technically challenging and is arguably one of the most critical steps in cataract surgery. It's also one of the earliest points where trainees tend to struggle. It requires precise control of tear direction under constantly changing forces and makes it difficult to master early on. And so much of the rest of the surgery depends on getting this step right. A well-formed centered capsulorhexis really sets the foundation for everything else to follow. There's a whole lot of proposed models out there that aim to teach capsulorhexis, but most of them remove the challenges that make the step difficult. Without a closed chamber and without fixed entry or true vector control, trainees can practice the motion but not the skill. And simulators, though excellent training tools, are often not accessible for frequent practice. They're expensive, as well as the commercial eye models often require recurring consumables. So the goal was to create an inexpensive, simple, reproducible, and mechanically relevant model that allows repetitive practice outside the OR. And I started with a dry lab desktop model, with the key features being entry point constraint and tear vector control under dynamic capsular tension. The concept was based on incorporating a closed chamber, fixed corneal incision or entry point, adjustable chamber depth, and an easily replaceable capsule. There's no specialized materials. The components are cheap, accessible, and easy to assemble, costing less than $5 per model. The reusable parts of the model are the cap and dome, which is a googly-eyed dome, and the replaceable component is only the blueberry. This enables high-frequency practice at minimal expense, and there's no need for recurring consumables replacements like viscoelastic or capsule analogs. So first I'd start with creating a 10 to 12 millimeter opening in the bottle cap. Then you remove the lid buckle from an artificial tear bottle and attach it to the bottle cap for chamber depth. The cornea is formed, like I said, with a googly-eye plastic dome and a 9 millimeter central opening placed in it. The dome secured concentrically, and a 1 by 4 millimeter corneal incision is made. And then finally the blueberry is placed beneath it. And the key is concentric alignment and maintaining a closed chamber and fixed entry point. So unlike open models, this design restricts instrument freedom. You're forced to pivot at the incision, therefore reinforcing that same movement restriction that residents struggle with early on in surgery. So although previous fruit-based models are helpful, they allow unrestricted movement, and this model aims to improve upon those by adding incision-based constraints. The practical advantages are that it can be practiced, repeated easily, with a rapid reset with new blueberry, inexpensive, and ideal for high volume repetition in preparation for before the operating room. And this was used informally by residents for repeated practice before going to the OR. Educationally, this, as I've mentioned a couple times, this reinforces instrument handling, position, and stability. I believe this helps young surgeons move from conceptually understanding capsulorhexis to actually performing it. It builds control in initiating, maintaining, and maintaining the tear vectors and giving trainees an awareness of this. And because it's accessible, it enables a type of repetition needed for skill development. The limitations, obviously, is it's not a perfect simulation. There's variability, as not one blueberry is like another. There's no zonular or fluidic dynamics, and it doesn't fully recreate the OR environment. Additionally, we didn't look at outcomes or skill transfer, and they weren't measured. It was more descriptive in nature. So the key takeaways is that capsulorhexis is foundational, difficult to master early on. training opportunities are limited outside the operating room. And so in summary, this model provides a simple but effective way to practice capsulorhexis mechanics in a more realistic setting than a traditional low-cost options that have been available or described. Can I go back? Whoops. And it's accessible, repeatable, easy to use. So moving forward, the goal is to validate skill transfer and outcomes, but also to invite others to iteration. I don't think that this is the final sort of model, but encourage others to build upon it and share it with others. I have no financial disclosures or funding, and here are my references. Thank you. Oh, yeah, sorry. Yes, questions. So, yeah. So what was that step that I was describing, the capsulorhexis that's difficult for residents and young surgeons? Let's see if I can, I guess my slides are done. Yeah, can you put them back up? So if you look right here, it's one of the earliest steps. Right after you make your main incision, you put viscoelastic in the eye to form the anterior chamber, and then you make a small opening into the anterior capsule. And if you can see, it's very faint because you're just seeing it off the red reflex, but it's tearing this perfect circle of the anterior capsule to give you access to the nucleus before you phaco and remove the cataract. And so you're trying to maintain this circular curvilinear capsulorhexis so that you don't have little tags that can then extend or have radial extension. You don't want that tear to propagate, through the posterior capsule, because then things can fall to the back of the eye. So, go ahead.
Analogy I always use is a peanut and a nut. Everybody's had one of those. So think of the nucleus is the peanut, the cortex of the lens is the chocolate, and it's surrounded by a candy shell. So you're opening the top part of the candy shell so you can get inside to break up the peanut with the phaco and suck it out, because you're not going to swallow the whole peanut, you'll choke on it, right? So you got to break it up. And then you pull out with, for the cortex, with a different instrument, your IA, and the key is to keep the rest of the candy shell intact, because that's where the implant slips inside of and holds the implant in place. But of course, the capsule is not thick or hard.
Yeah, it's a few microns thick. And so it's really important to kind of nail this step, because based on its size, its centration, all these different things affects where the lens will position in the eye, as well as just kind of predicts the rest of your surgery. So it can make things really hard if you don't do it well, and it can make your job a lot easier if you get it right. So.
Work on grapes, but I think blueberries are better because nowadays a lot of surgeons will use trypan blue dye
Yeah.
to stain the capsule.
Yep.
I thought, wow, that was pretty brilliant.
Yeah. And the main thing that I was trying to incorporate here is, like I showed, there's grapes or tomatoes that have been used, but it's kind of free-handed. So you get the idea of tearing in a circle, but you don't have to actually pivot through a wound. Whereas here, with that little fixed corneal incision, you have to grab, re-grasp, but then, pivot around the entire, yeah. Good? Right here? The cornea is, the googly eyes that they use for crafts, just from, a craft store. So it's the larger size of those googly eyes. You take the plastic backing off of that, and then just it fits perfectly over a water bottle cap. It's completely clear. I did find that you get some glare off of the center of that, so I just placed like a 9mm. I actually used a corneal turrifine and just opened up the center of that so that there was no glare shining back at me, because you don't have anything keeping it clear. Exactly. So it's more of a dry lab, just very entry-level practice before, it's not high fidelity or anything, but it just really practices the mechanics. So I just took, I wanted something that could kind of adjust the chamber depth, so to speak. So I just took, I think it was a Refresh Relieva artificial tear bottle, and that lid buckle was used just kind of as a spacer. And so if you put that concentrically just over your 10 to 12mm through the bottle cap, it just kind of gives what looks like an iris and kind of gives some depth to it. Yeah, yeah. Yeah, I should have brought a couple of them, but yeah, they're really easy to make, and I can just show you. You can make them yourself, just with. I do have a video on my laptop, so if anybody's interested, I can show you it actually being done, torn around, and you can see it. It tears very well, and it tears very similarly to the capsule.
Well, I think, and I know Dr. Costello says he teaches residents,
Oh, cool.
and so I think what he's looking at, what are probably the parts, the components, so maybe he wants to see.
Yeah, so all it is it's the googly eye, the top of any lubricant eye drop bottle, something to just cut through it. So I use like a 15-degree stab blade just to kind of cut my circle, and then super glue, just kind of align them concentrically, and then just blueberries that can be reused. Yep. So. Yeah. Thank you guys. Appreciate it.
So the next presenter is Reagan.
Hey y'all, good morning. My name is Reagan Boyette. I'm a third-year medical student at BCom Auburn, and I'm going to be presenting to you guys on a rare case of cataracts this morning. And don't worry, there's more to the story. Okay, so a 33-year-old male presents to the ophthalmology clinic to be evaluated for eye pain and pressure. It's been going on for about 8 to 10 months. He says it gets worse with bright lights. It's better when he lays down in a dark room. And upon physical exam, everything looks good. He refracts to 20/20, and I'll pull over to my next slide. On physical exam, all I really want you guys to pull from this is that his eye exam was normal. And so he started with ophthalmology and continued to work through to kind of find a diagnosis, but it was most likely migraines. So 1 year later, a 34-year-old male presents to the ophthalmology clinic with blurry vision. He said that 1 week prior, he had used a Theragun massage gun to his orbit and for 2 to 3 days in an attempt to relieve his migraines, and had ended up with this smoky vision. He tried to treat himself with sustained eye drops, but it didn't help his symptoms. On physical exam, he's 20/100 -2 in his right eye, and he's 20/40 -1 in his left eye, which is a huge jump from where he was a year ago, and this is with his glasses prescription. A few things that I really want to point out with his physical exam is that his anterior chamber actually had no hyphema or cell. It was deep and clear, and he had 3/4+ traumatic cataracts in his right eye and 2+ traumatic cataracts in his left eye. And you can also see a picture of what he actually looks like under the microscope. So treatment plan, he was counseled on his diagnosis of traumatic cataracts with probable iritis in both eyes. The ophthalmologist chose to follow up in 1 week and prescribed him prednisone eye drops, a Medrol dose pack, and 4 grams of vitamin C daily. And honestly, this was really a Hail Mary to kind of get the patient to come to terms with his diagnosis because he was being treated by an osteopathic physician. He looked at the whole person and knew that he needed a little bit of time to kind of understand what his next steps were going to be. At 1 week follow-up, the patient reported using his treatment plan as prescribed with no increase in his vision. His glare was pretty significant. He's still 20/100 and 20/40 in his right and left eye, respectively. And he has, again, the significant glare, which made driving really difficult, double vision, and light sensitivity. His traumatic cataracts had become 4+ in his right eye and 3+ in his left eye. So next step, the patient was counseled on his options for treatment, and those were to either proceed with cataract surgery or try to correct it with glasses. The patient chose to move forward with surgical correction. Phaco emulsification with IOL implant was planned for OD, and then 1 week later, they did OS. patient underwent uncomplicated cataract surgery, and his visual acuity was excellent after surgery. He, with refraction, came out to 20/20. And here's an actual video of the traumatic cataract, so you can see the cataract better in this video. A little bit about Theragun massage guns, because I'm not sure that there are any experts in the room. Theragun massage guns oscillate at a speed and amplitude of 30 to 40 beats per second and 10 to 16 millimeters. It can put out anywhere from 20 to 60 pounds of force on the eye, which you can see would obviously do some damage. About this case, it was uncomplicated. There was a little bit of fibrosis of the capsule due to the cataracts. There have been 2 other cases reported in the literature and one reported kind of anecdotally where the patient, again, had no hyphema. In one case, the patient had given themselves zonular dialysis, which for all the medical students in the room is like worst nightmare, boogeyman in the closet of cataract surgery. Another case report reported somebody giving themselves monocular traumatic cataracts, and the final case report, somebody had lens subluxation. Directly from the Therabody massage gun website, contraindications are direct pressure over the eyes or throat, because it can also cause vertebral dissection, or carotid artery dissection. Here are my references and acknowledgments. Thank you to Dr. William Sawyer for the opportunity to present this case and for his expertise in creating this presentation. I also want to thank Samantha Stambot-Stiles for her help in coordinating this patient's chart and de-identifying the patient information. Thank you guys so much for your time and attention.
Did you originally prescribe the Theragun to the patient?
That's how you get more cataracts. That's right. Making the volume increase.
That's a great marketing tool. Thank you for presenting that, Dr. Sawyer. Yeah, for mentioning.
So one thing she was alluding to, I don't know if you know Karen, Landon Karen, was talking to him, and he happened to have one, and he ran into, his was the one he ran into big time zonular dialysis.
Oh, yeah, that makes the cataract surgery trickier, that's for sure. Yeah, I was going to ask, your last slide showed that nicely, but I was going to ask if, is there some warning on the labeling of this? I've never heard of this thing, but you know, 'cause you have to, I guess, warn for everything nowadays, like don't stick a fork in your eye.
Right.
Fork,
Yes.
people are idiots, I suppose. Any other serious questions for the session?
Was there any zonular distance? I'm sorry, what? Zonular distance or no? In mine, thankfully, no. Well, that's what I was saying. Landon Karen had one, and he ran into it big time. But thankfully, on mine, they were okay. How long did this person use the Theragun?
They used it for 2 to 3 days, kind of consecutively over their eyes.
But I mean, in general, I mean, just using this for a year or? He was for some time, because he said he'd use it for his migraines, and he'd use it on his head, and then he just kept getting closer and closer to his eyes, until finally, because he always felt like his migraines were behind his eyes, until he finally just went at it.
Okay, so there was some logical, well, illogically logical reason
Yeah.
for why.
Yeah, he had a stepwise approach.
So just for a couple of days, but it was over the period of a year or whatever.
No. He had been using it, I don't even know how many times, like over months or a year. But the eye part, he had done it for 2 or 3 days.
2 or 3 days. Mm-hmm.
Was there one more question, or?
I was just curious about if there was on basis. I'm assuming that just makes the cataract exist during surgery, but for the lens, is that why it's, if there was significant basis, how would you do surgery?
That is a large question. It's one of the worst things you have to deal with cataract surgery, because the vitreous can come forward, causing insane amount of
surgeons, so like we like to fix things, and we see these patients that come in with like, oh, I've got headaches or migraines, or it's just a migraine, but I mean, they're acting like an idiot, but you can see the desperation. Like these headaches are bothering him so much, he's willing to take a massage gun and put it to his eye. So like, even these patients that aren't surgical patients for us, like, get them to primary care, get them to neurology, get them somebody to help them with their headaches. You know what I mean? Even when they're coming through our office, you know, a year ago, and so then they don't do these things out of like desperation. You know what I mean? So like, that's part of our job too, not just to do surgery, is to get people help where they need help.
Right.
So I think that's a take-home message from it too.
Yes, sir. The pain was very real. Obviously, he's willing to go to lengths to relieve himself.
Comment regarding treatment for headaches. One of the things that I found, I had a patient that had trauma from a motor vehicle accident, and his osteopathic physician referred him for cranial manipulation. And that was one thing after years of trying to find somebody to help her, that was one thing that did.
That's awesome.
We have or know of special skills that others may not know. That's true. Okay, thank you very much.
All right.
And, Susan, are you still here? Okay. You're next. Up we
Okay.
go.
Awesome. Thank you, guys.
Okay, hello everyone. My name is Susan Shaw. I am a rising fourth-year medical student at Des Moines University, and I'm currently wrapping up my research year with the Department of Ophthalmology at Mayo Clinic. Okay, so currently in the management of high corneal astigmatism. In the U.S., we only have an FDA approval of toric IOLs that go up to 6 diopters in the IOL plane, and which is equivalent to about 4 to 4.5 diopters in the corneal plane. And regular astigmatism can frequently exceed this range, and we see that in patients that are post-keratoplasty, have keratoconus, or have corneal ectatic conditions. And as such, custom-made toric IOLs with higher cylinder powers offer potential surgical solutions. High cylinder IOLs are limited in the U.S. mainly for concerns regarding rotational stability as well as refractive predictability. And so before jumping into this study, I wanted to quickly present a case that illustrates what can be achieved with this technology when it's paired with precise measurements, as well as IOL calculations that are in particularly challenging eyes. So here we have a 54-year-old Caucasian male that has bilateral pellucid marginal degeneration that is worse in the left eye than the right eye. He was able to tolerate soft contact lenses in his right eye, but in his left eye, he really struggled to tolerate any kind of lens, whether that be soft or hard scleral lenses. And at that time, he had about 12 months of stable corneal topographies, and this was his subjective pre-op refraction. As you can see in the left eye, he had significant astigmatism with about 11.25 diopters of astigmatism. And it's also worth noting at that point, he did not have any cataracts in either eye. And so, looking at these are his pre-op measurements. The axis was consistent between the two biometries and topographies, and the cylinder measures around 8 diopters in the center. And so in this case, if we were to use the Barrett toric calculator and use the high end of what's available in the US, that would have left him with about a residual astigmatism of about 3.65 cils, and which is certainly a large improvement from what he had, but it's still quite a bit of astigmatism. So after counseling the patient, he elected to do a clear lens exchange in both eyes, and he understood that using this kind of lens would be able to treat the regular astigmatism in the center of his cornea. So they used the company's help for this calculation, and which was Metacontour, which is a European-based company. And so looking at the different formulas, the recommendations that they decided to go with was about 9 diopters of sphere and 11 diopters of cell. And so after the bilateral clear lens extraction with a toric IOL, they did the left eye first and then the right eye. And as you can see, that was the power they ended up going with. And the results these are the 1 month post-op results. And the patient was actually very, very satisfied with the results, and he had he was actually surprised that he was able to get some multifocality in his corneas, and he was able to read up close. And so that brings us to our study, which the purpose is to evaluate the visual outcomes and refractive predictability of custom-made toric IOLs in patients undergoing cataract surgery with high corneal astigmatism. And so this was a retrospective study with patients above age 18 and older. There were 2 main groups, one being the high toric group that consisted of lenses greater than 6.75 diopters of astigmatism, and the standard toric group, which was 1.5 to 3.75 diopters. The toric IOL power calculations were done so using the Barrett toric calculator, and the Barrett True-K was used for any corneal ectatic conditions. And the outcomes that we used were post-op IOL misalignment, uncorrected distance visual acuity, residual refractive astigmatism, as well as predictive error. And so at baseline, the baseline characteristics were largely comparable between the 2 groups. However, it's worth noting that the high toric group did have significantly deeper anterior chamber depths as well as lower IOL powers. And so the high toric group consisted of patients that were diagnosed with pellucid marginal degeneration, keratoconus, patients that were post-keratoplasty, and there was one that had a previous pterygium excision. And so these are our results. Postoperatively, we did see that the high-powered toric IOLs resulted in significant decrease in astigmatism with an average of a pre-op absolute astigmatism of 7.88 diopters of cylinder, and the post-op residual absolute astigmatism was about 0.76 diopters in the high toric group. In terms of visual outcomes, the mean post-op uncorrected distance visual acuity was about 0.28 logmar, which is roughly slightly better than 20/40, and 82% of this group achieved less than 1.5 or less than or equal to 1.5 diopters of residual astigmatism. So that's the amount of astigmatism that was left in the eye after the lens was implanted. And so while we did see statistical significant differences, the clinical outcomes were comparable to the standard toric IOLs. When looking at predictability and rotational stability, we did see a greater predictive error in the high toric group, both in the spherical equivalent and astigmatism. As for rotational stability, there was no statistical difference between the 2 groups, but there was one case in the high toric group that required 17 degrees of misalignment, which required return back to the OR for redialing. And again, although the differences in predictability were significant between the 2 groups, the differences were clinically modest. And so clinically, we do see favorable outcomes with the use of the custom high cylinder toric IOLs, IOL cases in the high corneal astigmatism, as well as refractive predictability in complex corneas. So it's important to remember that careful patient selection is imperative while using multimodal measurements. But when done properly, these lenses do offer a reasonable surgical option when standard toric lenses are insufficient. And so these are my acknowledgement, my PI and my mentor. She's a wonderful, wonderful surgeon, cataract and refractive surgeon, Dr. Rudy Sella, who I will be eternally grateful for. Thank you.
We have some cornea specialists. Any questions, comments? Have you used specialty toric implants? Eye astigmatism?
same as?
So the ones we did this study in partner with a group in Israel, which is how we were able to get the data. Otherwise, he wouldn't have been able to even like get this lens implanted. But to my knowledge, I was told that it's quite a significant cost because they're custom made.
Okay, so I would have thought about that. Any other questions?
Well, I was just wondering whether you use any capsule tension rings. I found in my high myopes that sometimes a capsule tension ring is helpful in these toric lenses. Were any of those used?
For placement of the lens, I'm not really sure in terms of if there were any surgical complications and if there are like CTRs or CTSs used, but I will ask my PI.
Not because all of a sudden you notice it's on your.
Right, yeah, this is the high myopes that seem to have a little bit larger capsular bag than the standard that way. So sometimes it's helpful in these situations.
Well, that was great. Thank you very much. And I think we're actually have a few minutes. So those, if you, before we start at 7, if is breakfast still on? For those who didn't get it, this is your opportunity. Thank you very much for attending.
Is there any audio?
Yeah, there's a couple things.
There's a couple audio.
Yeah, and I'll just put the mic down and do it. That's what I've done in the past. Other side.
Put the mic down and do the
And then the
audio.
speakers. Yeah, just one that I'm gonna have audio on. Unless you have audio coming out of here.
I have a plug that we could test.
Okay.
I have, if there's a.
In the past, I've just plugged the mic down there and it works fine.
I'm trying to make this more stable. Yeah, I have it. There's a video switcher back there, so I have the control to do all that. Is there a way to move this sort of slightly?
Knock it over.
I have a handheld if you'd rather use a handheld.
Tell you what, so I don't mess up this thing when I'm introducing it, and I use the handheld, and
Yeah.
that way I don't pull your microphone down, knock your computer off, start the whole thing up again.
Yeah.
Oh, yeah.
Right there. That's great.
Put the shorter guys in front of the taller girls, etc.
Yeah, that is a timer. Would you, is there a specific time you'd like us to set you up with? Yeah, it'll count down.
This better be good now.
It better be, you're right. Ready, here we go. Everybody say capsule Rexes.
Capsular Rexes.
A couple more here. Heartful. All right.
All right.
No, I
plug your laptop into the sound, so it should just come through the speakers. We do have it recording, so that's the main reason, like, so it actually gets to the records.
Okay, good. There's one video I'm gonna turn the sound off.
Okay.
Cool. That here wanted to put some like death metal music on it. He and I go to Africa. It was like 15 years ago. He and I still go to Africa together. Yeah. In the short hair. He was like, yeah. So like the video is just like pounding death metal music. You can barely hear me talking.
That's funny. That's very, very funny.
Turn on.
Yeah. That's really cool. So that's cool. You change the format. A lot of videos. Yeah.
Yeah, Mac is nice. A lot of changes, you know, over time. This used to be PowerPoint, but it's like still works.
Yeah.
And now you're charging really well.
Right.
Microsoft's great.
The bigger thing is when you do something like, oh, you gotta use
Right. I've done it before, and I just like, try to put my stuff on the PC, and it didn't work. The videos don't play, the slides don't, the transitions don't work.
yeah.
So it's like both of the years. Yeah.
I'm glad we could just play. It's actually shows and boards. It's right now.
Yeah, it's huge.
Yeah, that four as well. Yeah.
Are they spread out too? Or no?
No, that's mine's a different. There's 4 years of this and yeah, it's super sweet. So yeah,
What's their age group?
16 and 14. Yeah, it's twins. So that's how actually
You get two more. So you were out of training.
no, my first one. The first one I had, clearly residence, and then everybody else was actually had second one. Several others. Yeah. And my middle one, he's actually still on. That was a lot of fun. The whole lot of fun.
No, I didn't take it.
They're in an easy age now.
Yeah, my older two are out of the house, which is great.
Yeah.
Still have a quarter. It's like,
Right.
let me sit up here. Let me sit down here.
You can. I'd just come on up here. I think we probably gonna need. The problem, of course, being 7 a.m. We're gonna have
Like,
people trickling in
you
while
guys have
you're
been
talking.
doing this all week. It sounds like we're last 3 days.
No, since Thursday. Yeah, Thursday. There's like an open reception Wednesday night, and then Thursday, Friday, Saturday, and then most people go home later today. Yeah.
Most people just sleep.
Right. Yeah. I apologize about the 7 a.m. spot.
man.
But yeah.
I mean, like I said, I'm up.
Yeah.
So that was great for me.
Right.
But I was like, oh, yeah, I was going to be there. Obviously, but when I saw them start at Thursday, I'm like, yeah, that's
Right.
conference I was attending. I'm like, later.
Right. But yeah,
We'll see.
we're definitely going to get people trickling in as you're talking because when you're the first one, that's what happens. Apologize.
Yeah, another
for that.
practice coming today, Kenyana.
Who?
Nathan Kenyana, he's the taco process guy.
Okay.
Winston group.
How about that?
Yeah, I saw his name. I was like, oh,
Oh
it's two
man,
of us.
thank y'all.
Yeah. Wendy
awesome.
Wong texted me and was like, hey, will you talk to this thing? I was like, sure. I guess she's probably recruiting him too, but I don't know.
I don't know. No, I don't think so usually.
No?
Well, I don't know. Maybe.
Was she like scheduled to do it and then like backed out?
Yeah, so she didn't realize that she was double scheduled for the board exams
Yeah,
at the same
board
time.
this weekend. Yeah.
And so that's what happened. She was, and then she was like,
Can't do it.
I cannot miss
That makes sense.
doing the board exams. It was like, oh yeah,
I didn't go to
that.
this week. I've been doing it for so long. I'm like, yeah.
Right.
It's just like,
Yeah.
just,
Yeah.
you gotta do it. This week.
Right. Let me find out real quick
Sure.
if
Ready?
yeah.
You want me to go 45 minutes or you want me? I have like 90 slides, so I can
feel like I'd probably go 45. 45 is pretty good because people have questions, all that kind of stuff.
So most of in the end, I can just kind of blink it just to see it because it's not like as relevant as the first
Okay.
30 minutes.
Yeah, that'd be great. That'd be great. Let me just check on this real quick. I'll be right back. So, no, we just usually shut them down. Get it going. Pardon? Should I just shut the doors? Get it going?
Oh, you read it?
Should I just shut it down and go? You guys good? Good.
Yeah, absolutely.
Okay. All right. All right. I'm gonna close that door then. Yep. Do you mind? We close that? Thank you. Pardon? Yes, please. Good morning. We're going to get started today. Our first lecture is ocular trauma with Dr. Alex Cohen. Dr. Cohen lives here now, but he's a board-certified, fellowship-trained cornea specialist. He got his MD, PhD from Albert Einstein in New York, and then he did his residency and fellowship at the University of Iowa. He then went to be faculty at Dean McGee Eye Institute in Oklahoma City, serving as the Cornea Fellowship Director. He then moved back to Iowa, where he was in a very busy practice, performing over 10,000 cataracts, cornea, and glaucoma surgeries, and then moved back to his home state of Arizona in 2025. He continues to serve as an oral board examiner and helps develop the oral and written examinations for certifying ophthalmologists. And additionally, he travels to Africa performing high-volume medical and high-volume medical and surgical eye care. And so let's welcome Dr. Cohen. Thank you.
Well, good morning, everyone. Thanks for having me. Thanks for getting up early on Saturday. My name is Alex Cohen. I'm a cornea specialist in town here. I developed this lecture several years ago. I used to be on faculty at universities, and I was talking about trauma consults. I know there's some medical students here, some residents, possibly some fellows. So this lecture is kind of geared towards things you might see in an on-call setting and ways to deal with them. So we're going to discuss how to identify and stabilize acute issues, such as those that you might see on call or after hours, or things that just wander into your clinic. So the first part of our lecture, just to get everybody on the same page, some definitions here: closed globe injury versus open globe injury, a contusion, which is an injury delivery from object that causes changes in the shape of the globe, lamellar laceration, partial thickness wound of the eye wall. It's not through, but into. We see that here in these photos down below. A rupture is a full thickness wound of the eye wall caused by blunt object. The eye wall opens at impact site or weakest point, such as an old cataract wound. It's produced from an inside-out mechanism. A laceration is a full thickness wound of the eye wall caused by a sharp object, outside-in mechanism. I promise I'm not going to talk the whole time. We're going to watch some videos to keep everybody awake. Okay, penetrating injury is an entrance wound. A perforating injury is something that goes through and through. Entrance wound and exit wound, both caused by the same agent. The most interesting perforating injury I ever saw was a guy who was tased by the police, and the taser bolt went through one side of his eye, out the other, and embedded into his medial rectus. That was a fun case to do at 2 o'clock in the morning. IOFB is a retained foreign object within the eye. All right, let's get in some cases. So concussive trauma, you might see this on call. This person comes in after, 2 guys, he was just minding his own business, and 2 guys jumped him in the middle of the night and beat him up, which is the general story we get in the ER. Here you see a subconjunctival hemorrhage. This is a nice old lady who we saw in the middle of the night. The resident there is doing a great job holding the eyelids open without putting pressure on the globe. And the question always is the globe open? Is this someone that needs to go to the OR now? Can we wait till later? How do we identify, how do we treat and manage these things?
So things specifically to look at, things you might see on call, or things in these trauma situations. I just had 2 of these come into my clinic last week. Things that you see commonly, traumatic mydriasis. You can get iris sphincter tears, trauma to the iris, and this can permanently alter the shape of the pupil. Less commonly, we might see traumatic meiosis, where the pupil constricts. This is generally associated with significant anterior chamber inflammation. And for these patients, we want to give them cycloplegia with atropine or something like that to prevent formation of posterior synechiae. So this is a patient seen in an on-call setting in the ER. You see that his pupils are not equal. He's got some anisocoria. And the question is, which one's the normal one? Is this something we need to worry about? So traumatic iritis is something we see as well. This comes into the clinic not too infrequently. Symptoms of these include photophobia, tearing, pain, and signs decreased vision, perilimbal injection, IOP reduction, or sometimes can even be elevated. The acute management of these includes cycloplegic agents and topical steroids if the patient is compliant. So again, in an on-call setting, we want to make sure we're not giving patients proparacaine. Our ERs like to do that and send them out the door, or steroids without any appropriate follow-up. And this can sometimes trigger a chronic or bilateral uveitis. So these are people that, in general, need to be followed in your clinic. So iridodialysis is something you might see as well. This is a traumatic separation of the iris root from the ciliary body. It's often with anterior segment hemorrhage, but you may not see this until the hemorrhage clears. So this is people you see on call, their eyes full of blood. You might not see this until the hemorrhage starts to go away a few days later. If these are small, oftentimes they don't require any treatment. If they're large, they can produce monocular diplopia, and this might prompt the need for surgical repair. So when I was at University of Oklahoma, I got referred this stuff all the time, whether it was traumatic from some sort of injury or introduced by someone doing surgical procedure. Obviously, if you see this, that's not normal. Here are a bunch of other ones that we saw in the clinic. You see a traumatic dehiscence of the inferior iris root there. And these can be very symptomatic. In some patients, however, they're not. And generally, when I discuss with patients whether or not we should do surgery on these, it's usually weeks to months after the initial injury, and they have a time to really assess whether or not this needs to be addressed. Doing these surgeries is not super easy, but it's also not super complicated if you kind of follow certain principles. Here's a video a surgical repair video we did several years ago. This is with one of my fellows. This patient had cataract surgery, and during implantation of the intraocular lens, the iris root was dehisced significantly, and this was referred to our clinic because the patient was, number 1, unhappy, and number 2, was having monocular diplopia. So my fellow at that time, Michael Wagner, he really liked to name things and do cool videos. So we call this a scleral weave excluding knot. This is a technique we developed where I'll show you what we're doing here, but basically we're gonna make a large conjunctival peritomy, put some viscoelastic in the eye, try and get the iris off of the IOL. It's been there for a while, so it's pretty well stuck down. And then just try to pull things back to where they belong and try to see what can we do here to repair this. These are not easy cases. You want them to try to look good. So here we've sped this video up, but we're passing a double-arm CTC 6L needle with a 9.0 Prolene through a paracentesis that you see in the upper part of the video. And we're going to engage the iris and then bring it out through the sclera. We're not making a flap here, and that's what the purpose of this technique video is. So we take the other arm of that same needle, make sure we're going through the peritomy, because we're going to bring this double-arm suture through, and you'll see that it loops through and brings the iris down to the sclera. And then we just place a single throw just to put a little bit of tension on this. If you try to tie this knot, you're going to end up with a knot that erodes through the conjunctiva. If you put these under flaps, which I've done many, many times, they can also erode, especially larger suture like Gore-Tex. I've seen that so many times where the Gore-Tex erodes. This is Dr. Wagner operating now. He's passing the another needle, doing the same thing on the other side. And then the purpose of this technique is that we're going to demonstrate how we apply tension, basically, without making a knot. So this can be used in many instances, whether you want to suture a CTR in, scleral fixate a lens. What we're doing is basically passing the needle back and forth, the 2 double-arm needles back and forth, kind of weaving it. So that's why we named it the scleral weave excluding tie technique. So the goal here is to make this kind of look like a shoelace. And what that does is puts enough tension on the suture so that it's not going to pull out, unless there's really significant trauma, without having to tie a knot. And I've done this in other cases as well, and it works pretty well. I mean, I know nowadays a lot of people are doing things like Yamane and making flanges and bulbs, which is great as well. I've done plenty of that stuff. I've done that with iris work as well. Having done this for 15 plus years and followed patients and had lots of patients refer to me, I've seen pretty much everything possible erode through the conjunctiva and sclera. All those Yamanes, I've seen plenty of those come out. I've seen lots of intraocular scleral fixated lenses erode through. So a technique like this kind of avoids having a knot, and you're not going to have erosion. So that's what we want it to look like. We put some Myocol in there. We saw the pupil is not round, so we decided to use a Siebser internal sliding knot technique here to bring the iris together to make it look a little bit better. So another double arm CTC6L needle. Pass this across the eye through the iris. And then I don't really have great video of the Siebser knot technique, but basically you pull a loop out of the eye, tie outside of the eye, and then pull the knot in. So it's an internal sliding knot technique, which I have lots of other videos demonstrating that. There's a lot of stuff online about that too. And we're just closing the perimeter there. So in the end, looked pretty good. Patient was very happy. Patient's diplopia was gone. A lot of work, but I think in the end, worth it for the patient. All right, so move on. So traumatic hyphemas are something you'll see in these situations as well. These result from injuries to vessels of peripheral iris or anterior ciliary body. They mostly occur in young males because of trauma. Injury to vessels of the peripheral iris or ciliary body, about 50% of these might occupy less than a third of the anterior chamber. Less than 10% might fill the entire anterior chamber, and an 8-ball hyphema is the term we use to describe a total hyphema. Here's a patient with a clot in the anterior segment, in the anterior chamber. Okay, the big risk with hyphema and the big thing you want to be concerned about is rebleeding. The rate of this is anywhere between 3 and 30%. Generally occurs 2 to 5 days after the initial injury. The complications associated with this are elevated eye pressure, glaucoma, optic neuropathy, and then corneal blood staining, which when I was a cornea fellow, this was like, we were all really scared of corneal blood staining. But now having done this for so long and watching these patients, it's amazing to me how much blood staining actually clears. Because when I was a resident fellow, I was taught that if there's any blood staining, this person's going to need a PK. In reality, that's not necessarily true. I mean, definitely it can happen. If you have rebleeding, this generally has bad outcomes. Blood staining, the risks of this are high IOP, so when the patient's pressure is 40, let's treat that. If there's endothelial dysfunction prior, there's significant anterior chamber blood. In kids, we want to watch for amblyopia. This is someone you might take to the OR sooner. When I was at Iowa, we used to admit these people because we had our own inpatient ophthalmology ward, which was amazing. And you just admit these kids and have them, with bed rest and nursing staff that would round on them all the time. And then we'd send the residents and fellows to go take care of them too. The histology shows red blood cell breakdown, products in the stroma, which can take a long time to go away. When it does clear, it clears in a centripetal pattern, very, very slowly, but from the outside in. And sometimes, like I said, these may require an optical PK. So the management of hyphema, the goal is to reduce rebleeding. So we want to talk to patients about placing a shield, bed rest, elevate the head of bed, see daily or every other day if they're a compliant patient, avoid things that might make them bleed again. You can give them cycloplegics, topical corticosteroids, and pressure lowering drops as needed. Oral corticosteroids or aminocarproic acid, these are things that can be used but are somewhat debatable. So surgery in a hyphema, so if it's an adult with a hyphema that you're worried about corneal blood staining, there are a lot of different techniques. You can just simply wash it out, which I've done plenty of times. Our faculty at Iowa and Oklahoma like to do a tube or a trab and just let it fail. They would do a trab without mitomycin in a kid and just let it fail so that the pressure would be okay if their pressure was high to begin with. So obviously this is bad. You don't want to see this. When you see this, this patient may need PK, but if they're not in the amblyogenic age, if they're a 50-year-old man, I would just watch this, and you can watch this for weeks or months, and it may clear. There's really no rush for a PK. When I was first in practice, I did a lot of transplants on people with keratoconus and other diseases, and I remember people coming back to me the next day or a week after surgery and thinking that they should see clearly after their full-thickness corneal transplant at week 1, and why don't I see better than I did with my keratoconus? So when I talk to patients about corneal transplants, full-thickness transplants, I say we're changing one problem for another problem. We're going to get rid of this, which is bad, but we're going to give you a transplant, which is better in some ways, but also a lot of interaction between myself and the patient. So we have to kind of make that deal that we're going to do that. All right, so let's move to something else, non-perforating mechanical trauma. So this is stuff we see a lot. Conjunctival lacerations. This is something that's referred to my clinic frequently, generally by our optometry colleagues who see this in the office. As non-surgeons, they're concerned about what to do about conj lacs. In general, you just want to make sure there's no injury to the deeper structures, there's no foreign body present, vegetable matter, et cetera, that we need to clean out of there so they don't get a really nasty infection. Generally, you can put some proparacaine in, explore this as a slit lamp with sterile forceps or cotton tip applicator. If they're a non-compliant patient or you're really worried about if you've got a really nasty conj lac, you might go to the OR to explore, because sometimes you can have deeper injury that you can't identify in the ER or your clinic. So if it's in isolation, generally you don't need to suture these, but you definitely can. I typically stay away from that. Anybody in the room suture these frequently, or do you tend to leave them alone? Leave them alone? Yeah. Depends on the size. Yeah, I agree. So conjugal bodies, these are things we see all the time. Just need to examine the patient's slit lamp, invert the upper lid, make sure you examine the eye fully. I'll show you an example of this later. Explore the inferior fornix, have the patient look down, really look up in the superior fornix. Place fluorescein and look for fine linear corneal abrasions that are characteristic of foreign body. So here's a good picture of that. This is foreign body tracking. When someone comes into your clinic and says, I feel like there's something in my eye, and you look and you don't see anything, and then you put fluorescein and you see something like this, I would recommend looking again. Make sure you evert the upper lid. Make sure you really look well. You can see this. I had a patient 2 weeks ago where I had clear foreign body tracking, but I couldn't find anything, and I think that it had just washed out like earlier that day or something like that. I saw a patient yesterday in clinic, actually, who works in the ER, and he came in with foreign body, and he was just adamant there was something in his eye, and he'd been looking, and I've seen this now probably 4 or 5 times. He actually had an eyelash that was into one of his meibomian glands, stuck up in the meibomian gland, so rubbing on his cornea. No one in his ER could see that because it just looks like an eyelash, and just grabbed some forceps, pulled it out, and he was instantly relieved. He shook my hand. He's like, "You're amazing. Thank you so much." It's like, well, thanks. Has anybody else seen that? Yeah, so it's uncommon but common. I mean, it's really cool to see, and you're like, oh, this is easy. Why is that there? And you pull it out of the meibomian gland and you cure them. Yeah, they can be the punctum too, that's for sure, yeah. It is like a serpent, yeah. It's amazing how they get in there. And I've seen them underneath old surgical incisions, in the conjunctiva embedded. You just pull them out. So corneal foreign bodies, these are things that walk into our clinics all the time, referred by ERs. You see them in the ER if you're taking an ER call. If this is a full thickness corneal foreign body, we want to be careful taking these out at the slit lamp, because you're going to perforate the eye and create a leak. When I was on faculty at University of Oklahoma, I had my cornea clinic in one lane, and the residents there have a resident clinic, which is staffed by an attending who's not really there. And they would talk to me about, I would give lectures to them about corneal foreign bodies, and I say, never use the ophthalmic burr in the clinic, because you're going to perforate the eye. And if you do that, don't come talk to me, because I'm not going to help you. And then, a couple weeks later, a resident comes around the clinic and says, Dr. Cohen, we perforated the cornea. I'm like, put some glue on it. Go take care of that, But I would just caution people, be very, very careful when you've got a corneal foreign body. See how deep it is. If you're not comfortable gluing a cornea and you think it's deep, send it to someone who is. Glass you might see, and it can be deeply embedded. You can leave this in the cornea because it's inert. It's not going to cause a problem. I've seen this in patients. The glass has been there for years and years and years. It's sent to me as, second opinion. We found this in the eye, and you talk to the patient. They had some trauma, 25 years ago. This has probably been there forever. You can watch it. If it's iron containing, you want to get this out soon, because it can create a rust ring, create other issues. And with metal, I've seen this several times as well. You want to try and get this out, because you can get a persistent epithelial defect, which results in poor healing, inflammation, corneal ulceration, can even result in perforation. So the treatment of this, irrigate the eye. There are many different techniques to remove corneal foreign bodies. My preferred technique is a bent 30-gauge needle, which you see here. That's not typically the way I bend it. I bend it with bevel up, and then just look at the slit lamp and remove this. And then you see kind of a spud next to that you can use as well. I really don't like the ophthalmic drill, because it looks small to us, but then when you put it up next to the foreign body, it's like usually 10 times the size of the foreign body. And I had a patient in a clinic where one of our ODs, the patient came in 2020, little corneal foreign body, and the patient got the foreign body out and then burred out the rust ring, and then sent the patient to me about a month later because their vision was 20/60, and as the cornea specialist, I'm supposed to fix that, right? But if you do a topography or tomography, you see a tremendous amount of induced irregular astigmatism, and that patient's cornea is now, I can't fix that. I had a patient like this early in practice. I ended up doing a PK on him because he was so debilitated by his central depression in his cornea. So I would just caution people, if you're not used to using a drill, don't use it. Use a 30-gauge needle or something else where you're not going to create a huge, deep crater in the stroma, because while the stroma can fill in with epithelium, you're going to forever alter that person's corneal topography, induce a lot of irregular astigmatism, and potentially reduce their best corrected visual acuity. So this is a patient seen on call setting. You see multiple corneal foreign bodies there, both eyes. It's pretty common in Iowa with the farmers doing stuff on their machines. They're underneath some sort of machine and stuff falls in their eye. All right, so corneal abrasions, these are seen frequently on call as well in your clinic, in the ER. Symptoms, obviously pain, foreign body sensation, tearing. The causes, generally you see my 4-year-old scratched my eye. I was just minding my business and someone punched me in the face. I had that this week. Pieces of paper, propelled foreign bodies, contact lenses. We need to distinguish these from ulcerations, which have inflammation and corneal thinning. We want to look for the foreign body, or look for a foreign body that may have caused this abrasion, make sure we're clearing the whole eye, not just focusing on the cornea. Abrasion treatment, oftentimes we can use ointment, antibiotic ointment like erythromycin, just because it's thick and gummy, makes the patient's eye feel better. And then cycloplegism just for pain control as well. This is in an ER on-call setting, or a patient you don't know or trust. Like I said, I had a guy last week who came in who was minding his own business, and 2 guys beat him up, and he was incarcerated thereafter, and then saw me, and I don't know if this guy's ever going to come back to me. So bandaged contact lenses are great. I love bandaged lenses. I use a ton of them. But if I don't trust the patient, I don't want to put a bandaged lens in them and then never see them again. I saw a guy recently with a really nasty ulcer who had a contact lens in his eye for 2 years. So you want to be careful, because you as the doctor that puts that in, you're forever on the record as doing that. And if you don't follow up with that patient, the patient doesn't come back and they get an ulcer or infection, it's your fault. Patching I would advise against in a trauma setting or on-call setting, because you can induce infections this way or cause infections. One of my mentors, his mantra was never patch a contact lens associated with epithelial defect, because your incidence of infectious keratitis is actually higher if you don't. And you want to follow abrasions involving organic material closer than you would something else, right? Because these people are at risk for fungal keratitis. This is a patient seen by an ER physician. They would call us in the middle of the night all the time. This is what they're seeing. A lot of the ERs that I've taken call out or worked at, they don't have a slit lamp. Their slit lamp doesn't work. They don't know how to turn it on. They don't know what they're looking at. So they use this thing called a Woods lamp. And they would call us in the middle of the night and say, I see scleral uptake. And you're like, what does that mean? I don't know if your guys' ERs say that too, but this is what they're talking about. Big abrasion, obviously seen with the Woods lamp, which is a cool tool, and it's something they see. Some of the ERs that I've worked with more recently are really good at taking care of this. They don't even call us about it. They just start the appropriate therapy and have them follow up the next day without waking us up in the middle of the night. Okay, let's talk about open globes. So the vision is really the best predictor of final vision, like the initial vision. If this is a unilateral injury, which often it is, you want to check for an RAPD, because that can be predictive of final outcome, and also kind of direct your surgical management. Does anybody here take call and do open globes? All right, great. Comment if you have any comments, please. If there's any possibility of an open globe, you want to avoid forced ductions. So this is stuff that I would teach to our residents. You don't want to gonio them. You don't want to do tonometry. Eye care is great nowadays because it doesn't put any pressure on the eye. And you definitely don't want to scleral depress them. Go ahead.
I'm sorry to interrupt, but that's what I wanted to clarify. I think I feel comfortable using eye care if I suspect an open globe. Is that true? If I can do that? Because I don't even need to have anesthetic.
Yeah, no, I totally agree. Eye care, as long as the patient can open their eye, or if you're opening their eye, you're opening it on their orbital rims, and you're not, really mashing the eye open and squishing the eyeball. I think eye care is great. I think it's a great invention. I really love it. I love it in the cornea clinic. When I first started, we didn't have eye cares, and people would say, can I stain the cornea to check pressure? And my answer was always yes. Most of the cornea specialists said no. And we had great techs that were awesome at application tonometry, which most of my clinic still does that. But if it's a cornea patient, I just tell them, look, use eye care. If it's a post-op, we did a PK or DSEC or whatever, use the eye care because it's easy and it's atraumatic. In this setting, I think it's awesome. And some of the ERs I worked at actually have eye cares, and they're pretty good at using them. But I would not tonopen them. I would not applanate them, especially if you're not comfortable doing that in this setting, and oftentimes you can't. That's good. Yes. No, I remember that. We used it in the OR when we first started doing DSEC in like 2007 in Iowa. We were using Shiatsu in the OR to see what the IOP was as we had them laying flat. And at the bottom there, life-threatening injuries take priority. One time I was on call and I got called to the ICU for a patient who had, a small injury, and they were worried about an open globe, and they saw a tiny little orbital fracture, and they had me come examine the patient. And I go into this room, and he's got a tube in, he's got this whole gauze on his head, and I'm trying to examine the patient, looking at his eye, and I take my gloved hand off of his gauzy head, and his brain is coming out. And then, of course, all the neuro people come in. I'm like, what are you doing here? You consulted me. I don't know. What am I doing here? Why am I here? It's 2 o'clock in the morning. Why are you consulting me? Clearly, I'm the least important human being in this room right now. I'll just go. But some ERs, the residents just, we got to consult ophthalmology, blah, blah, blah. And of course, sometimes we're free and neurosurgery is not. Where I did my residency fellowship, we had an on-call room that was next to neurosurgery, next to trauma surgery. There's 3 on-call rooms: ophthalmology, neuro, trauma. And as a resident, I should have known that was going to portend bad things, that we basically stayed in the hospital for call and didn't go home because we were super, super busy. But it was a great experience. So signs of an open globe: things that are suggestive: deep eyelid lax, orbital ecchymosis, conj lax, hemorrhage, significant hemorrhage, focal iris corneal adhesion. Look for that. Saw one of those recently. Shallow AC, obviously iris defects, hypotony. Look for lens capsule defects. You might have a foreign body that's gone through the lens. An acute lens opacity. I had one of those this week. Retina doctor who did vitrectomy and caused a really nasty cataract in a 41-year-old. Didn't really tell me that he ate the posterior capsule. I was very suspicious, and he had a huge hole in his PC. Thankfully, he was able to get the lens out. Diagnostic of open globe. When you see uvea sticking out, that's not good. Vitreous, retina, not good. Positive Seidel test, visualization of IOFB. With Seidel testing, sometimes when you're testing these patients, if their IOP is 4 or 2 or 0, it's not going to flow, right? But if you see it, that's concerning. If you see an IOFB on ultrasound or X-ray, concerning. CT scans are great in hospitals, ERs, because the ER doctor usually gets that before they even call you sometimes. And they can do some blood testing if you want or need to. I would advise against MRIs. They're really impossible to get anyway, but we don't want to do MRIs in a foreign body situation unless it's something like organic. Acute management, when these people are seen at outside ERs, you want to tell that ER doctor, hey, put something on their eye, a cup or whatever, tape it over their eye so they can come to our ER and take care of them. Avoid frequent topical meds that require prying lids open, especially important in parents with kids because they're going to try to get those drops in and they're going to be mashed on the little kid's eye. Make sure you keep them NPO. So very important, if you're not the one doing the surgery, if you're sending them to a retina colleague or someone else, be kind and say, hey, don't go to McDonald's on the way to so-and-so's office because then they can't take you to the OR for 6 hours, and that's not cool because now they're going to be going at 3 a.m. instead of normal time. Antiemetics, pain control is appropriate. IV antibiotics or PO. There was great stuff that came out of the wars in Iraq and Afghanistan. The military saw that if they give soldiers PO Moxie and they would carry it with them in their kits, if they take 1 PO Moxie, it significantly reduces the incidence of endophthalmitis. That was presented in an academy meeting years ago, but that's a good thing to have or to do as well. All right, so surgical repair, the goal is obviously to restore the integrity of the globe. Having done lots and lots of trauma call, sometimes that's all you can do, and that's really what you want to do. Get in, get out, make the globe watertight if you can. Primary nucleation is a topic of discussion. Does anybody do that? Anybody frequently do that? So some people do. Where I was at Iowa, it was an absolute no-no. You didn't even discuss it. Where I was at University of Oklahoma, our oculoplastic surgeons were a little more attuned to that and might do that in certain situations. Typically, you would delay the enucleation for a few days, but you don't want to wait too long because they can get sympathetic ophthalmia, which is not good. If you do delay, you can allow for retina evaluation and confirm that this patient is really has terrible vision before you do that. So here's a patient seen on call. We see a lack of his brow there and underneath his orbit, and he's got swelling chemosis of his lids, which makes the exam difficult. He's probably drunk too, so they're never super cooperative. Deep laceration there. You guys have ENT guys here too, so this is great. They can sew this stuff up for us. And then the question always is, is the globe open? How do you tell? Well, if you look at this eye, it's very concerning. You've got bullous subconcheme, but you don't know for sure. You have a CT here now, and if you look carefully at that CT, you see one globe on the right-hand side of your screen is normal, and the other globe has a bunch of stuff in it, right? So that's bad. When we see this on call, we know, okay, this person has an open globe, and we need to go in there and fix it. Here's another patient seen on call in the ER. Bumped her face in the middle of the night, and you've got blood coming down. her cheek there, her eyes all swollen. A little bit difficult examination, again, as the globe open. We've got subcontium. If you look closely at the image on the left side of the screen, you'll see that there's some hemorrhage in the anterior chamber. And then pulling the eyelid up, again, very gently, you're holding the eyelid on the superior orbital rim. You've got a bullous subconjunctival hemorrhage. This is great also because you can get a CT scan here and you see the eyes full of blood. So you know the globe is open even though you can't see the laceration. You don't know where this is. Sometimes these are really, really posterior and you have to really explore the eye. I did one of these years ago and I remember opening up the conj with the resident and just digging, and all of a sudden a lens just squirted out with us from like where the optic nerve was. Like, oh, okay, there it is. That can be really tough to close. So here's a kid seeing the ER, looks nice and happy, smiling at us. You notice he's got this little tiny red spot right underneath his eyelid. He's got anisocoria, so suspicious here of trauma, subconjunctival hemorrhage. Looking closer, maybe a little conjunctival epithelial defect there. And then on CT scan, we see this little bright spot right at the edge of his sclera there. So he'd actually been shot in the face with a BB gun. So we knew that history, obviously, but we had to go in there and remove that. All right, so here's some surgical videos. These are cases that I've seen, some recently, some a little bit of time ago. First one's a 75-year-old man presented to a referring provider after slipping in the bathroom and hit his face on the countertop. How many people have seen this same story like 100,000 times? Yeah, so super, super common. Saw the referring doc for 3 days in a row, and the referring doc was like, there's just this weird pigmentation of the conjunctiva superiorly. Maybe he's got melanoma. I do a lot of ocular surface tumors. So they sent him to me for, is this an ocular surface tumor? I'll show you what this case looks like. I think this one might have sound. All right, so if we look closely here, you see the pigment of the superior portion of the eye. Anybody else see anything else there? Yeah, some blue stuff. So blue stuff doesn't belong there, right? So what's that? Those are haptics. In the olden days before phaco, people used to do superior scleral tunnels and extra caps. So you can look at these patients who had surgery years ago. This is an extra cap wound that basically broke open. And if you're not familiar with that surgical technique or not aware of it, that's the weak part of the eye. So when I was introduced, I talked about how I go to Africa. So every year for the past 10 years, I go to Africa and we do manual small incision extracapsular surgery. So you make an incision superiorly, scoop the lens out, put a new lens in. But these are big incisions, right? So before we did a 2.2 millimeter phaco incision, you were doing 6 or 8 or 9 millimeter incisions, right? So these things are weak. And that's what we saw in this instance. I'll just show you what we did here. So obviously the patient's aphakic. With that lens up there superiorly, we put some triamcinolone in to stain the vitreous. This is kind of an older video. I did an anterior vitrectomy with the older outcome machine with the larger instruments and lower settings than we have currently. And then made a prudotomy superiorly and removed this foreign object.
Since the conch was over the tissue, to just pull the lens back down.
Yeah, I thought about what to do here, but there was such a mess. There's so much vitreous in the anterior chamber, and it was just a disaster. We just wanted to basically close this eye. I have a lot more experience now than I did in this day. But yeah, you could do something like that. But there was no support. We would have had to scleral fixate that lens somehow, which I've done plenty of times. You could externalize those haptics and tuck them or whatever you want to do. Those haptics are kind of brittle, so when you try and externalize those, sometimes they pull off or come off. Anyway, so we just sealed that incision. It was kind of tough to seal that broken area because there had been so much other stuff going on there in the past. And then we went back later and put a lens in. Oftentimes I don't do that. I think in an on-call or trauma setting with an open globe, you don't know if there's infectious material in there. This globe was not technically open, like you said. There was conch sealing it. So you probably could have got away with doing one surgery and suturing a lens. All right, here's another case. This one actually does have sound. Can you guys play it? Okay. Let's play it through this.
Laceration, a traumatic cataract, and an intraocular foreign body. Here we're staining the anterior lens capsule with trypan blue so we can see the entry wound. Here you see the hole in the anterior lens capsule, and we're using the cystotome to try to incorporate that hole into our capsulorhexis. The retractor forceps are used to complete the capsulorhexis. You see it's off center here, but it does incorporate the initial tear, and it is continuous. We know there's a hole in the posterior capsule, so we skip the hydrodissection and hydrodelineation steps and just use the phacoemulsification needle to debulk the lens. Now we've switched over to a bimanual IA to try and remove the nucleus and cortex. This is a young person, so the lens material comes rather freely. If you look closely here, you can see the hole in the posterior capsule just behind the cannula tip. So the temporal incision was sutured closed and the case was turned over to Dr. Shaw, who's now performing some anterior vitrectomy.
Shaw's our retina specialist I work with.
Looking through the biome here, you can see the intraocular foreign body and the impact site. He's just doing vitrectomy here to loosen up this foreign body so that it can come anteriorly. Once it's free of the vitreous, he grabs it with the cutter and brings it anteriorly. We're planning to bring it out of the clear corneal incision so we don't have to make a large sclerotomy. So viscoelastic is injected into the anterior chamber. And then the foreign object is pushed up through the posterior capsule and grabbed with retina forceps and brought out of the clear corneal phaco incision. Next, we're doing some scleral depression here and just performing some laser barricade around the impact site and some retinal tears. The case has been turned back over to me now, and I'm just forming the sulcus with viscoelastic in preparation for lens implantation. This is a 3-piece lens that's going into the sulcus. You can see the lens is deposited on the anterior capsule. I like to use these MST duet forceps to bring the trailing haptic inside the eye. I find that this puts less pressure on the leading part of the lens. Now we're using bimanual irrigation aspiration to just remove the viscoelastic material from the anterior chamber and suturing that incision with a single interrupted tenonylon. We're finishing up here by taking out the vitrectomy ports. This patient's done really well. At his last visit, his vision was 20/20 with correction.
So Vinay Shah and I did that case together, and we had a whole series of these, where his point was that we're not making a sclerotomy to take out a foreign object, where if you do it in conjunction with the anterior segment surgeon, you can then take this foreign object up through your phaco wound. And we had like 10 or 12 of these cases that we presented as a different take on a surgical, on how to do the surgery. All right, so this is a case I saw a couple weeks ago. This is a 62-year-old man presented to a referring provider after bumping the eye on the bedside table at 2 a.m. So again, same thing. Saw a referring doctor 1 day ago. Referring doctor's exam, vision was 20/20, IOP was 19. He, in his note, he noted iridocorneal adhesion and noted that this was sidal negative. He referred to me for a second opinion. I was in a super busy clinic trying to get to the OR. I sat down. I looked at this. Does anyone see something abnormal? So we recognize it. You know, the referring doctor is a great doctor. He's an OD, but he didn't recognize that this was iris coming out of the cornea. OD with tons of experience, really good guy, really smart. I sat down and looked at this and said, we're going to the OR. I'm leaving in like 30 minutes. See you there. You know, so we added him on that day. This is sidal negative because the iris is plugging up the wound. Having gone to Africa so many times, I've seen innumerable patients that have been stuck with these huge needles in the eye, and they get a full thickness corneal laceration through their iris, through their lens. And what I've realized over time is the iris is like the omentum in your belly that we learned about in med school. It like goes places and sticks there. It's like it seals things up. So we see these patients with these iridocorneal adhesions and scarring, and their lens gets resorbed, and they did okay. They didn't get endophthalmitis and lose their eye. So we come in as the mission doctors and put a lens in the eye, and oftentimes they do well. This patient, you know, in our country, obviously we don't want to let this sit. We want to get them to the OR sooner rather than later. So this is that afternoon. I'm just wiping off any epithelium that might have grown there, any dirt. Tried to put some Myocol in, didn't do anything. irrigated this for a long time to get off any stuff that was on there. And the question is, do you reposit iris or do you cut it off? I've cut off plenty of them when they look necrotic. This looked pretty decent still, and the guy was really worried when I said I might cut your iris off. He didn't like that. So that's some some Provisc, or sorry, fluid, trying to get that back in there, balanced salt solution. That didn't work well, so I just put some Viscoat in the incision, and then was able to close this incision. Rinsed out the eye. And then the concern here is obviously infection. You know, this eye has been open for a few days. Is this guy going to get an ophthalmitis? That's the concern. And if you put necrotic iris back in the eye as well, I mean, you worry about inflammation and what's that going to look like. So I've definitely cut off plenty of irises. Here we put intracameral moxie in the eye, closed up. Saw him the next day. His vision was 20/20. Saw him at week 1. He had some AC cell, and I was concerned about infection, obviously. Put him on antibiotic drops as well. Saw him at week 1. He's 20/20. His iris is just like slightly distorted, a little bit peaked, so I'm glad I didn't cut it off. And he sees 20/20, and he's super happy. So good outcome. All right. This is another case that came into our clinic recently. 45-year-old man presented to a referring provider feeling foreign body sensation after cleaning the grill with a bristle brush. Probably very busy clinic. This doctor saw him. Vision was 20/25. IOP 17. Mild lid edema was noted on the examination. This is a representative image, but this is what they saw, some upper lid edema. And the diagnosis was chalazion, and the treatment was hot compress. One thing I learned in med school and residency and fellowship and in life is that your diagnosis must make sense with the presenting complaint. So when a patient comes in and says, I think there's something in my eye, I was scraping on a grill, they don't have a chalazion. Like, that doesn't make any sense, right? And we want to find the lowest common denominator, like what is the diagnosis that explains everything? And that, I've got many, many, many stories about that. But then anyway, this patient came to us for a second opinion, and my colleague here pulled the eyelid up and examined the eyeball, which was not done at the prior clinic, because now you see something black sticking out of the eye, right? Like, that shouldn't be there. And thankfully she didn't pull it out of the eye. She thought about it and then thought better of it. And that's what it looks like. So that's not normal either. There's this big, massive thing sticking in through the eyeball, right? So that's a wire brush from the cleaner that shot him in the eye and was stuck there for days. It's pretty big too. So the point of this was, remember to examine the patient fully. If we're in a busy clinic, et cetera, if it doesn't make sense, start over, remember our eye exam, start from the beginning, really examine conjunctiva, examine everything, so we don't miss stuff like this, because that's really bad. Imagine had this patient got endophthalmitis and lost their eye. I mean, that's just not good. This was actually sent to retina, so retina guys did this. Yeah, so this was seen by one of my colleagues, and she showed me the images and had already sent the patient out the door to retina. But yeah, I think with this, because of where it's at, it's important for them to take care of it, because they're going to do laser barricade in the OR, which I don't do anymore. They did vitrectomy. Yeah, they did a vitrectomy. There was a little tear there. They lasered it all up, put some nice barricade in, and patient's doing fine. They put some antibiotics in there as well. Yeah, I don't remember exactly which ones, but yeah, they injected antibiotics, did a vitrectomy, clean it out. I think one of the goals of vitrectomy, or one of the benefits of vitrectomy as well, is you remove all the vitreous, and that's a great media for things to grow in, so you get rid of that, and people can do well. All right, we're going to shift gears here. We've got about 4 minutes left, so I'll go through this quickly. Chemical injury is something we saw a tremendous amount of in Iowa, and where I lived in Oklahoma as well, and this is something that I think stumps a lot of doctors. So just to go over this quickly, different forms of chemical injury, it's important to ask the patient's history. Is it an alkali injury or an acid injury? And nowadays with cell phones and looking things up, I just look it up because I can't remember all this stuff. Different types of acids, different types of alkali. We had all these farmers who were getting this sulfuric acid or sulfurous acid in their eye in Iowa, and also people making meth would get this stuff in their eye. So just to discuss kind of briefly what we're looking for here, when you look at these patients and evaluate them, you're looking at the degree of limbal stem cell injury, as that's the prognostic or rate limiting factor in healing. And the degree of corneal inflammation and its control is a prognostic modulator within the limitations established by limbal stem cell status. So what that means is, when you see these patients, it's important to treat them appropriately. I had a patient recently who was seen by another doctor for 3 months, and had they treated them as I'll describe, they would have done much, much better. So with chemical injury, we get inflammatory cells that migrate in, we've got epithelium that needs to grow back in, and keratocytes, And this gives us a corneal healing pattern. When you initially evaluate these patients, you want to look at or grade the limbal stem cell injury, as this gives you some diagnostic indication of how they're going to do, or prognostic indication. The surface area of the contact, the depth of penetration, whether or not they have limbal ischemia is very important. Identify and confirm the healing pattern. And this may not be apparent for a few weeks, but let me get more into this here. So this is a grade 1 injury where you see no stem cell injury, just an epithelial defect there inferiorly. And these people heal normally and have good recovery. This is probably the most frequently seen thing in private practice. Grade 2 injury, you have partial stem cell injury here. And they may heal differently. They can have delayed differentiation. They can have conjunctival epithelium that heals over the cornea. And this is what we're trying to prevent, because these patients can do poorly. Grade 3 injury, you have total stem cell injury. And these people heal with a fibroblascular pannus. So the goal here is to try to prevent this from happening. And the way we do that is by treating them appropriately. So grade 4 injury, this is where they can get ischemia and end up getting a perforation. So the immediate priority when you see these patients, and I know this is some people have struggled with this, is we really want to control inflammation. The subsequent priority is stem cell deficiency and the healing pattern. We want to downgrade the healing pattern from a grade 3 to a grade 1 or 2 and save this person's vision, which you can do. So immediately irrigate them. Oftentimes the ER has done this for you. Debride necrotic corneal epithelium and conjunctiva to help it heal faster or better, and then institute the appropriate topical and systemic medical therapy. Kind of run out of time here, so I'm going to go through some of this stuff quickly, but in the acute phase, you've got limbal stem cell proliferation, epithelial migration, and you have the first waves of inflammatory cell infiltration. Importantly, there's little or no collagenase production and little or no collagen synthesis. So it's important here to help the epithelium heal with lubrication, bandage lenses like we talked about earlier, Procaras, AMTs, which you can do in the OR. But the most important thing here is topical corticosteroids. And I'll stress that because, again, the patient I saw most recently, had he been placed on topical corticosteroids, he would have done a lot better. And I've seen this many, many times. We used to have a burn unit. We take care of these patients all the time. Systemic RX, like doxycycline, sodium ascorbate, and then other things you can get that have to be compounded, which we had a great compounding pharmacy at Iowa. Medroxyprogesterone, sodium ascorbate drops, citrate drops, antibiotics, cycloplegia. Ascorbate is something that's been talked about in the literature. I've seen this work really well. What it does is it reduces the incidence of corneal ulceration by increasing collagen synthesis and stromal repair, because the AC levels of ascorbate are low after an injury with alkali. Citrate can also be used. This helps prevent chemotaxis and the release of lysosomal enzymes by white blood cells. So we're trying to balance out and tip the scales in our favor of collagen synthesis versus collagenase activity. So in the early phase of repair, you want to continue doxy, because that helps prevent MMP activity, continue systemic sodium ascorbate, so oral, and then importantly here as well is you want to discontinue or taper topical corticosteroids. So in the first few days after chemical injury, you can use steroids almost with impunity as long as you're covering with antibiotics, and obviously watching the patient closely, but then afterwards you need to taper these. Because you can increase, when you taper the steroids, you're going to increase collagen synthesis by keratocytes rather than suppress it, so you end up with less perforations. Medroxyprogesterone is great to continue if you can get it. It limits those white blood cell dependent collagenases. All right, so I think, are we out of time? What's that? Time for questions? All right, I'll skip the rest and we'll go with questions. I think it depends upon how they're looking. I mean, generally, a week after you would start tapering. I mean, obviously, they're ulcerating in front of you. You're going to end up doing something different. But steroids, I mean, if you use them initially, people will do really pretty well. I think in our world of cornea, infectious keratitis, and these type of things, steroids can be used appropriately as long as they're implemented judiciously. People have a good outcome. But obviously, steroids have risks. Other questions? B-scan, yeah. Yeah, I have a B-scan in my clinic. I'm reasonably comfortable using it, but when I'm have questions that are more than just, is the retina on or off, I'll send them to the retina guys. And we have great retina guys in town that'll see them same day. I sent over a fungal keratitis yesterday with a really nasty hypopyon, and had the retina guys just take a look and make sure that there wasn't endophthalmitis that was going to make me do surgery sooner rather than later. Go ahead.
For chemical injuries, do you typically have the ER physician start steroids?
No. The ERs I worked at would consult us. They would, in general, call us, and they don't care because they're shift workers, so they'll call you at 2 a.m. and be like, hey, what's going on? Like, well, I was sleeping. Oh, okay, too bad. So they generally would consult us, but I have not worked with ER physicians that are, in general, competent or feel comfortable starting steroids. And when I would lecture to our ERs and go talk with them, I would tell them not to. I'd tell them, use Cipro for contact lens associated keratitis rather than gentamicin ointment because your patients will be better taken care of. But I generally don't direct them with steroids. Some of them are really great seeing AC inflammation with uveitis and actually will start steroids. And they'll call me and say, hey, I see 2+ cell. This patient has HLA-B27 associated iritis. Great, if they're comfortable doing that. But in general, I would not in this situation. I'd go see the patient or have them see me the next morning. Go ahead.
So you were talking about with the bird, in regular stages. But I've even seen that sometimes with just corneal abrasions that heal that way. Is there any indication of a particular type of patient that that's going to happen versus normally where they normally heal fine without any problem?
You're talking about abrasion or something that involves the stroma?
I've seen it with abrasion, but it wasn't even that deep where they just heal back regularly. But when you look at the photography, it's just crazy.
Yeah, that's definitely true. So I've done lots of PRK in my life, lots of ALKs, anterior limbal keratectomies, and you will see irregular astigmatism. With all of our great topography machines now and OCTs where we can look at epithelial thickness, you will see that for sure. But in general, that will go away. If it doesn't, what I'll do is a superficial keratectomy and anterior stromal puncture just so they don't get a recurrent erosion. Put them in a bandaged contact lens for like 3 months, changing it monthly, keeping them on antibiotics during that time. And in general, that takes care of it, and they do really well. But you can definitely see that. Go ahead.
For iris case, that you repositioned the iris so nicely, I have a question. You chose to push the iris through the incision rather than going and sweeping in it. Is there a reason for that?
Just felt better. No, I think you can do either way, and I've definitely done both ways. It was easier when I started just to push it in, and my tech was, she's saying the same thing to me. I've seen doctors just go in and sweep it in. I'm like, yeah, I've done that too. But it went in pretty easily. Things I've seen where you try to sweep the iris in is I've actually seen people go in, having trained lots of resident fellows, and try to sweep things in too aggressively and dehiss the iris. And then the eye fills with blood, and then you're stuck sewing the iris. So I don't know. I just try to be gentle, but I think that's totally appropriate in certain situations for sure. Just from where I was sitting, it was easier to push. If I was sitting superiorly, I could have then swept it in. So just situational. Any other questions?
In a trauma case where a full corneal laceration, traumatic cataract, no intraocular foreign body, after you perform the primary repair of the corneal laceration, how much time do you give for the second procedure for cataract?
I think that really depends. So I actually saw a patient last week with the same thing. We have in Arizona, we have like this trauma mafia that I'm not part of because I don't want to do that anymore. But the trauma mafia had closed the globe and then had the patient follow up as a young kid, had the patient follow up, and he developed a really nasty cataract, came to see me for a second opinion. He came into my office with pressures of 40. His lens capsule had been violated, and his eye was full of lens material. So that patient, now has phacolytic or phacoanaphylactic, whatever it's called, glaucoma, right? Their pressure is really high, it's not controlled. They need surgery, and they need surgery like ASAP. But I've also seen patients where there's violation of the lens capsule, and that doesn't happen. The lens doesn't hydrate, and they tend to do well. So those patients, I'm hoping to just do a cataract surgery. Like a patient who actually got shot in the eye with a gun. Bullet fragments hit them in the eye, and the bullet fragments were within the lens. And that patient, as long as they don't have an infection or any reason to do emergent surgery, they're going to do better when the eye is quiet. We can get the stuff out and put a lens in. Because when you put a prosthetic in, you always worry about if there's other stuff in the eye already, are they going to get bacteria buildup or fungal buildup on this lens, and then have to have a lensectomy or that lens removed, right? So those are my concerns. But if the eye's quiet, you can do it sooner rather than later, or if it's indicated in the case where the lens is really fluffy and causing an acute issue. Any other questions? All right, well, thank you guys very much.
Good. All right. And just do.
Extended view. Yep, and then I'll put it up there. I just
Thank
have
you
to
so
switch
much.
it. Yep. And then, yep, this is all good.
All right.
And then, yeah, the clicking will just kind of
Yeah,
be...
that's fine. No problem. Do I go off stage? It was funny. I was like, I need my laptop. I don't know if I can see that far to like read my notes. Yeah, of course. I feel like I'm gonna bore everyone to death after the ocular trauma. Half of this talk being surface disease. Yeah, it was really good. Yeah. Oh, really? Man, you've had a hard year. Yeah. Yeah, it definitely seems like he likes to teach. Yeah. That was like ghosts of open books past for me, though. I'm like, oh, they got another way to go. Do you do a lot of open books? Or your private practice, right? Yeah.
I used to do a ton of them.
Yeah. Yeah. The stress levels. Yes. For sure.
You know, it's fun to do though. It sucks to
Yeah. I know. You're like, oh, I'm in 2020.
Right.
Your eyeballs falling out of your head.
Right.
You're lucky you're not in plastics clinic right now. I know. I don't know. Let's see. It is 8 a.m. right now. Give it a couple minutes. So I was thinking, I was talking with a couple of people on the education committee for next year. Do you think it would be reasonable to do like per hour? Say have like 2 20 minutes and then a panel?
my hair looks. Who's on the
Yeah, that'd be nice. Like more interactive.
like a couple years ago, who was this?
So we'll have a few people that do like complex intersay. It'd be cool to like put up cases and just see how they would.
Right. Last year in New Orleans, we did a like it was. This was actually a cataract panel, but yeah, we had a guy that was from there. And he does podcasts. He's really good.
Yeah.
And yeah,
Who was
they.
it? Michelle?
And oh, I know. And he's great. It was like they didn't have enough people. He's like they asked me last second.
Oh,
Are you
you're
doing
like,
a panel?
you're like, what are the cases?
Sure. Yeah. And so, but yeah. That's we've done panels in the past.
Oh, I was
for
thinking of doing
40
that if I could get a couple people. I mean, it's an hour, 1,000 per hour, so then I would just have to.
I have to remember that. I'll have to ask on that because it's
So I
like
wanna, like,
it kind of depends. Like, well, like for instance, depends on who you're pulling up. Like if you're pulling people from the community, yeah, you're probably gonna pay them. But if it's probably something from our college,
Yeah.
a lot of us will just be like, yeah, I'll pay up there. You know what I mean? That kind of thing. And so I don't know that like I think it's more like
When you're trying to get people
Yeah,
to entice them.
right,
Yeah.
exactly. So yeah. But yeah, that's totally fine.
Because then I was
Yeah,
thinking
people
like maybe the
panels.
glaucoma and the cataract cornea day, and you can get all those people on the panel. 'Cause
Yeah.
they always do the cataract.
Right.
Yeah.
We've had it before too, though.
Too many panelists, yeah.
Everything.
And then more.
No,
Gotcha,
no,
gotcha.
every
Right.
lecture, panel.
Okay, yeah. And you don't want that as much.
Yeah, yeah.
Yeah.
And make sure it's good.
Yeah.
Make sure it's really good. And it's been a while since we've done cornea. I think it's been years since we've done cornea lecture. Yeah, I'm good with that.
Like
I'm good with that.
get some people that like to chat.
Right, exactly. Yeah.
Just have to do the like play off music if they talk to me.
Right.
Cut the mic.
Right. That's right. Yeah. No, that's good. Good. These are the parts that make me just be something. You know what I mean? Like,
Yeah.
like, because I do feel like there should be a transition time,
Yeah.
but it doesn't feel like that's built in.
It doesn't. I know what you mean. Yeah, maybe we should do that.
Yeah, that's not a bad
5-minute break.
Be like, yeah, everything's got 5 minutes.
Yeah. Not a bad idea.
I wanted to make sure that that door was closed.
Yeah.
Okay, we're going to get started with our next lecture. So, if you will, let's welcome Sarah Bonafini. She's Sarah. Where are you at now?
I'm in South Jersey. No
Okay.
leopard print today. But
All right. So she's in South Jersey. She went to LECOM in Florida for medical school. She then went to Philadelphia for her residency and the University of Tennessee in Memphis for a cornea fellowship. And she's been an active member in our college and helps us out a lot. She's going to talk on cataract surgery in bad corneas.
thank you for that introduction, and thank you everyone for spending your morning with me today. It's going to be a hard transition from ocular trauma because we're going to go into ocular surface disease for a bit, but I will try to be a little brief and try to bring some new techniques that you can take home with you and start using in your practice on a day-to-day. So the lecture today is cataract surgery in bad cornea, so we're really going to cover the gamut here. So I am a speaker for Bausch and Lomb. So cornea disease and cataracts. So the optimal timing of cataract surgery in individuals that are presenting with concurrent corneal disease does really necessitate careful consideration to enhance their outcomes and optimize their refractive results. Our patients are having increasing expectations for superior vision after cataract surgery. So this really underscores our need to recognize these corneal pathologies prior to entering the surgical theater. That's from ocular surface disease through Fuchs dystrophy and even looking at the retina. So I'm going to be covering dry eye. We'll talk a little bit about herpes keratitis, talk about trigia, SLK, a couple dystrophies that are more common. I won't bore you with lattice and granular. And we'll talk about corneal scars, BNK, and keratoconus. All right, so some tried and true treatments for ocular surface disease. So the ASCRS submits a clinical survey. It was actually updated this past year on how dry eye actually affects cataract surgery. And about 90% of their respondents feel that mild to moderate dry eye does impact patient satisfaction in cataract and refractive surgery. I think especially now because we are implanting a lot of intraocular lenses that are premium lenses, multifocals, EDOFs. So really having a pristine ocular surface is important for success and 20 happy with those patients. The update with the 2026 guidelines, which we found out a few weeks ago, have also included neuropathic dry eye, so that's going to be pain without stain. So those are those patients we maybe want to be thinking or hesitate before we do refractive surgery. We can still do cataract surgery, but really counseling those patients. So we know that corneal changes in the central 3 millimeters can really affect our outcomes, as you can see here with the fluorescein staining, the placido disc, and we also want to be looking at the lids. So we have a variety of imaging modalities in order to assess dry eye, from meibomian gland imaging, anterior segment OCT to look at tear meniscus height, topography, looking at tear breakup time or surface irregularity, interferometry, looking at the thickness of the lipid layer, and aberrometry. So just a general overview. So we have a couple flavors of dry eye or ocular surface disease. We have our aqueous deficient dry eye, evaporative dry eye. We know that dry eye is inflammatory. We have an uptick in the inflammatory cycle whenever we're dealing with dry eye, so cutting that down with a steroid is very helpful, especially in preparing these patients for the OR. And then in our more severe patients, we can treat them with additional therapies for sometimes months before we actually get to that point where we're taking their cataract out. And we'll talk a little bit more about these in detail. So our aqueous deficient, we want to be thinking more artificial tears. Our patients are often already on artificial tears by the time they see you as an eye care provider. Punctal occlusion, cholinergic agonists, and a new kid on the block, TRMP8 agonists. So how many people use punctal occlusion? A lot of people using intracanalicular plugs or silicone plugs. Yeah. So I think punctal occlusion is a great thing to do, especially as a first-line treatment. It's great for pre-op patients, great for post-op patients. It's a procedure you can do in the office that you can bill before you start down this track of doing drops. So I think something that we maybe should be reaching for a little more, punctal occlusion. We have lots of options. So we have our collagen or intracanalicular plugs, which are great because they sit in the lid. They don't sit on top of the lid. We want to be careful with the silicone plugs, although they are great for some patients. We want to really monitor how they're actually sitting in the lid. They can fall out. You want to stain those people after you place those plugs with lissamine green to make sure that it's sitting on the eye correctly. You're not getting abrasion of the conjunctiva because then that patient will be back in your chair. Cautery is a good option. I usually will just do this in the office, a little lighted with epi, low temp cautery, stick it right in the puncta and fire. You can treat them with an antibiotic or steroid ointment for about a week after. It's a great option for patients that are coming in multiple times a year for plugs and have had good success. I have been doing, so cautery here, I have been doing a fair amount of Lacrophil in my clinic, which I actually really like. So this is a cross-linked particulate hydrolonic acid hydrogel, lasts for about 6 months. You don't have to worry about sizing. That's always a little frustrating in the clinic when you're looking for different sizes. You don't have that one size in stock. So I really just use either 25 or 27 gauge cannula. I usually will numb their eyes just with tetracaine, and it takes like a minute, and I go through the inferior, and then depending on your angle, it should come out the top. So you're basically blocking all 4 puncta. It is considered a complete occlusion versus punctal plugs, which is considered more of like an 80% occlusion. It's thought to have a decreased infection risk because there's no bacteria in the cannulicus, so if you're doing a complete occlusion. However, it can be flushed out. So that's a good option that I have been utilizing and reaching for quite a bit. You do need a tech to help you because you'll be using the joystick on your slit lamp, making sure the cannula is in the right place, and then I usually have my technician push because otherwise you kind of need a third arm to do that or have a very, very still patient. Okay, so cholinergic agonists. So this is a nasal spray, which I'm sure you have all heard. This is a good option for patients with dry eye disease that potentially maybe are in contacts. I hate eye drops. It's been out for a few years. It increases the Schirmers for long duration, not just with sneezing. This can be a good option for the right patient, just another tool in your toolkit. New kid on the block is triptears. So this is a TRPM8 agonist. So these receptors are cold sensation receptors expressed in the corneal sensory neurons. When they activate, they send a signal to the ophthalmic branch of the trigeminal nerve. This regulates the lacrimal gland activity, and this triggers an increase in reflex and basal tear production, which is going to increase your aqueous and your lipid layer. The COMET 1, 2, 3 studies did show significant increase in tear production, shown by Schirmers, compared to vehicle on day 14, improvement in subjective patient scores as well. Again, another tool in your toolkit. Moving on to anti-inflammatory, so we know we have to stop that cycle of inflammation. Oftentimes we'll do this with a steroid, loteprednol is popular, and then we can maintain them with cyclosporins, lifitegrast, preservative-free Dex. So we have lots of options to reach for. Typically, I will have patients on maintenance therapy once we get their flare under control. So don't be afraid to use steroids to stop their flare and then maintain them with one of these modalities. Kind of pick your journey here. Okay, and then we're moving on to evaporative dry eye. So we know that we have aqueous deficient, but we also have evaporative. Evaporative tends to be the bigger piece of the pie here. Doxycycline, I'm sure a lot of us use for the lids. There's lid procedures that are available. Is anyone doing LipiFlow or IPL, iLux in their clinic? So that's an option. Coverage can be a little difficult, so kind of figuring out that balance. Some people will offer it as a med spa add-on. PFO, or perfluorohexaloctane, is fairly new. That's great for evaporative dry eye. And Lotilaner, I feel like sounds like a German beer, like Lotilaner. I usually call it by its other name. So doxycycline, we know through studies that this can help by modulating the MMPs, and it's been used for many years in evaporative dry eye. Very helpful in blepharokeratitis. This is a patient pre and post. After Doxy 20 and Pred maintained with cyclosporin and Tacro, we can see a regress in the NNV, and that cornea looks a lot healthier. Lid procedures, so thermal expression can be helpful. There's a variety of these: microblepharoexfoliation, tear lab, and then IPL, which is a photothermolysis. It's one thing to keep in mind. If you IPL patients with missing glands, we can't get that atrophy back. So if you start this treatment earlier, that can be helpful. Okay, so Lotilaner. So this is an antiparasitic formulated to target Demodex. Has gotten a lot of attention. They've done great with their marketing strategy. I have patients coming in and asking me, do I have those mites? So they've definitely done very, very good with their marketing. So this blocks insect and arachnoid and the GABA chloride channels, causing mite paralysis and death. It's used twice a day. It's used for 6 weeks. Patients like that, it's not an indefinite treatment, so they're really just using it for 6 weeks and then they're done. I typically do have them use lid scrubs as well. In addition, there's an 80% collaret cure. Their data shows a clinically meaningful reduction to 10 collarettes or fewer. You can always use tea tree oil for patients that can't get this medication covered. So perfluorohexaloctane. So this shows a decrease in the total corneal fluorescein staining, as well as VAS scores. Tear breakup was not looked at in these studies. It does stabilize the tear film. However, it was proved in 2023. It met its endpoints for both BID and QID dosing. It's pretty well tolerated with pretty minimal side effects. Sometimes I'll use this in my clinic before I do biometry in order to evaluate the patient's ocular surface. Sometimes I get better readings if we just put one drop in the clinic. Additional therapies, so these are for the more severe patients, so serum tears. There's companies out there that will help you with the serum tear process, because sometimes that can be difficult for private practices to set that up in their clinic. In that same vein, there's also plasma-rich and growth factors, which is just like serum tears, but a higher concentration. There's amniotic membranes, there's scleral contact lenses, and then us cornea people have another acronym for you. Anyone heard of DMAC? All right, we're going to talk about that. So autologous serum and plasma-rich and growth factors. See, these are both blood-derived eye drops that are used to treat more severe ocular surface diseases. PRGF is considered more concentrated alternative to serum tears. This can reduce the squamous metaplasia that we often see in these patients' cornea. Amniotic membranes can be helpful. They're self-retained or cryopreserved membranes, thinking more Procara, and then are dehydrated, which are placed, I typically place them under a BCL. So sometimes I'll put them on the cornea and then put a BCL, or sometimes you can just put it in the BCL itself and then stick that on the patient's eye. So this is actually a physical barrier thought to improve corneal nerve regeneration. I like this more so in flares for ocular surface disease. Persistent epithelial defects, neurotrophic keratitis, or high-risk superficial keratectomies. So that can definitely be something to reach for in some of these more severe patients. I don't tend to use this for my mild dry eye patients. And then we have additional therapies. This is more the scleral contact lenses in these patients where you've really tried everything. You can consider doing a scleral contact lens. Working with a good optometrist is really helpful for these patients. It's like having an aquarium on their eye, and is often very good for, say, our Sjogren's or patients that are just incredibly dry, and we've tried a lot. So this is DMAC. So this is kind of the new thing that I learned about this year. Again, this would be more on the severe side. This is not something that you're going to reach for, the mild to even moderate dry eye patient. So basically the steps are: superficial keratectomy is performed, donated corneal tissue is tree-fined to an appropriate diameter to fit within the edges of the epithelial debridement that you just did with your superficial keratectomy. You want to allow about 0.5 millimeter clearance on all edges. You then place that tree-fined corneal button with the allograft side down into the corneal surface, staying within the margins of the debridement, and then allow the corneal button to dry, and then you just peel it off, leaving the allograft in place. So you're really just leaving Descemet's on the eye. If there's wrinkles, you kind of want to smooth it with a little cannula. You're going to gently sweep it onto that cornea to smooth it out. And then fibrin glue, use a little fibrin glue on the cardinal points to ensure that it's fully in place. And then you put a bandage contact lens on top of that glue. This will incorporate into the natural cornea. It does take time for this to incorporate, so this is not something where patients are going to get good vision the next day. This is something that's takes 3 months, 6 months in order for you to see a stability in the corneal topography before you would consider then doing their biometry, their pentacams and whatnot for cataract surgery. Is anyone doing this yet? Any of my cornea people in this room doing this yet? Not, it's fairly new. Okay, and then we have some things in the pipeline. So with dry eye, there's all these options, all these drugs. It can be very overwhelming, and that's because we don't have one drug that treats dry eye. So it's finding, I like to tell my patients, not everybody likes the same cocktail. We have to kind of find the cocktail for you. So we have to make sure that we're addressing your flares, but then maintaining you. And then not every person is going to have that same maintenance therapy. So there's a lot of research in this field. Some things coming down the pike. So Reproxalap, this is a RASP inhibitor. This is decreases ocular inflammation. It's more on the allergy pathway, so this is going to be more with our vernal or atopic dry eye. This is still in phase 3 trials. AZR MD001 clearly hasn't been named yet. This is a selenium sulfide ointment that's applied to the eyelids that dissolve keratin plugs and improve meibomian glands. This is also still in phase 3 trials. Tivanisiran silencer RNA aimed at the TRPV1 receptor. It's dosed daily to basically shut down your corneal pain signaling pathways. This is phase 3 as well. And then visocolmitide, which is a collagen peptide mimetic, which is, repairs damaged collagen and helps repair corneal epithelial collagen damage during dry eye. This is also in phase 3 trials. So just some things to look forward to. Okay, and then just a couple intraoperative tips for ocular surface disease. I like to power wash the cornea if I see a lot of oil in the tear films. As the patient blinks, you'll kind of see like these little sparkles going over the surface. I'm sure we've all been there. So if you just turn your IA on and just power wash that cornea for about 10 seconds, that'll clear all that oil out, and it makes it a lot easier to do your capsular rhexis. So just a little tip there. I like to use a little viscoelastic on the cornea. It does magnify, so just be aware of that, but that can help your technician not having to squirt BSF every couple seconds if you have a patient that is very dry during those very important steps of the procedure. You want to take care with the lid speculum. Oftentimes in older lids, they can get lag or exposure keratopathy after cataract surgery if we really crank those lids open. So just be aware of that in some of our older patients here. And then if I have any viscoelastic left over at the end of the case, I do tend to just squirt the rest of it on the cornea before or after we do the eye drops in the eye, and that can be helpful. Oftentimes patients will complain of foreign body sensation that first night after their cataract surgery. So if you have any viscoelastic, don't waste it, just use it on the cornea, and that can be helpful. Okay, so with our dry eye, we also want to be thinking of all the other pathologies that could look like dry eye, so we don't want to miss these things. So just a little review here. Not everything is dry eye, so we do want to rule out other things as a diagnosis of exclusion oftentimes. Okay, so let's move on to some cases. So this is case 1. This is the patient that comes into your office, dryness and burning. She's tried a variety of things. She's still dry. She wants cataract surgery, and she wants to be glasses free. You stain her with lissamine, and this is what you see. Anybody know what this is? Shout it out. Yeah, gold star. All right, so this is inflammation of the superior bulbar conjunctiva and the limbus in the cornea associated with filaments. Corneal inflammation can be associated with thyroid, RA. You can consider a rheumatology consult in these patients. You want to treat this prior to cataract surgery, oftentimes with steroids. This can definitely affect your biometry readings. I do tend to, when I see new dry eye consults or even my cataract patients, I'll stain them for the first time with fluorescein and lissamine just so I'm not missing anything. So something to keep in mind, steroids, punctal occlusion, anything that's going to decrease that desiccation stress and that superior conj. So one thing that some people will do is cauterization. So you can actually cauterize this area. It looks a little intense, it heals pretty well, or you can resect the superior conjunctiva. You want to be thinking blepharospasm as well. Sometimes patients with blepharospasm will present like this. So sometimes I will do Botox to the pretarsobicularis near the eyelid margin of the upper and lower lids. You want to watch for lag, want to watch for dry eye, but this can be helpful getting them through that flare. Obviously, you want to warn them of a lid drop. Okay, so moving on. So chronic irritation, blurry vision. This is a 66-year-old female. Presents with eye irritation. She's asking for the light adjustable lens because her friend got it and she doesn't need glasses. So she sits in your chair and this is what you see. So you see this superior staining. You flip the lid and you see all these little guys in the tarsus. What are we thinking this is? This is correlating to the staining. You can yell it out. Yeah, so these are concretions. So these are degenerating epithelial cells or mucinous secretions from the conjunctival glands. It's associated with chronic inflammation, aging, MGD. Typically, it's asymptomatic. When you see this, you don't have to go removing them. It's only if they're symptomatic or causing an erosion. You can stain with LG, and they'll actually light up with LG or fluorescein. Just pop it out with a 30 gauge or a jeweler. Treat with Moxie, lodiprednol for a week. Other treatments you could consider for long-term avoidance is AMT, steroids, cyclosporins, lifitegrast, or pros. But oftentimes, you pop this guy out, patients are happy. Okay, so this is case 3. This is a patient with a foreign body sensation. They've tried all these things. They want cataract surgery, but they're worried that their eyes are going to feel worse. So in the slit lamp, you take a look and you see this abnormal area in the lower lid. What do we think this is? So this is, conjunctival chalasis, I heard it. So this can be associated with decreased tear clearance, which can be associated with an ocular irritation. Typically, patients have worse symptoms in the morning. It can be associated with aqueous deficient or aqueous deficient dry eye. These are OCT images showing that redundancy. There's a couple ways in which you can address this. One way is just right in the office. You kind of pinch that extra lid skin. I like explaining it as a tummy tuck for the eyelids. You pull that extra skin down and then you just kind of cut it off or you shrink it back. So really just numb that eye up, lidocaine gel, have the assistant hold the lids, high temp or low temp cautery, angled forceps, and then just linear cautery to that lower lid. And that tear clearance should look a lot better. The other way that you can do this, which is a little more unique, is you can inject a little glue in that area that you've marked. And then you pinch it with your forceps, and that will seal the edges together. And then you just cut it off. It looks like a little worm. Same thing. So you can fibrin glue, yep. So you can schedule it on your pterygium days. All right. So this is a 46-year-old male complaining of red eye and photophobia. So I'm sure we all know what this is. No cornea talk would be complete without this. Let me yell it. Yeah. I'm sorry, it was new. I'd have to, I'm not too sure. Yeah, I know like some people use radio frequency pens. Is that what you're referring to, radio frequency pens? Okay. Okay, so this is herpes keratitis. So this can present in a variety of ways, epitheliogeographic, stromal, or endotheliitis. You definitely want to ask patients if they've had a history of red eye, photophobia, pain, or if they've been treated for this in the past, because they have a perioperative schedule that they should follow 3 days before or 2 weeks after surgery. You want to put them on antivirals. This is the dosing that I do. You don't want to do a beautiful cataract surgery with a multifocal IOL and then end up with this. And then instead of scheduling their other eye, you're calling for Oxervate. So definitely ask about this prior to taking them to the OR. And then this is my perioperative dosing for Zoster, which is just double. Okay, so moving on. So how can we prevent zoster? So we want to encourage our patients to get the shingles vaccine. So Zostavax was the older vaccine that reduced the overall incidence of zoster by 51, burden of illness by 61, post-herpetic neuralgia by 66. Shingrix, even patients that have had Zostavax, we want to consider having them do the Shingrix, which is about 89% effective against zoster. And now we have prophylaxis because the ZEDS results are out. So this is a study that has been going on for quite a few years. And now we know that putting patients on antivirals significantly reduces the occurrence and severe eye disease at 18 months. The 12-month outcome was actually not statistically significant, but the 18-month outcome did show patients treated with 1 gram of valacyclovir had a 27% lower risk of new or worsening eye disease, keratitis or iritis, fewer flare-ups, 30% at 12, and 28 at 18 months, and pain reduction at 18 months. And I think most importantly or interestingly in this study, it actually lowered the need for gabapentin. Because even when you get them through that initial stage of zoster, they're complaining about this post-herpetic neuralgia, which can really be debilitating. So if there's something that we can do to try to prevent some patients from getting that or lower that need for some of these drugs that help control their post-herpetic neuralgia, then we should do it. So I think a lot of cornea specialists were already seeing this anecdotally, but now we have the data to actually back it up. So I would keep your patients on Valtrex. And then a question I got in previous years of when to do the vaccine if they've had an active infection is you want to wait at least 12 months prior to getting the Shingrix vaccine after infection. For immunocompromised patients, you can work with their primary care doctor. Sometimes they'll recommend it a little sooner. And you want to wait until age 50 if they're immunocompetent. Okay, so this is a patient with a history of herpes infection, blurry vision, considering cataract surgery. So we can see on the cornea that little guy that shouldn't be there. So that's a little neovascularization. So we know that avascularity is the reason for corneal clarity. Any kind of insult to the cornea, infection, inflammation, hypoxia, trauma, bypasses that safeguard and disrupts the immune privilege of the cornea, which leads to inflammation and envy. NV is very difficult to treat, so we want to try to avoid it in the first place. But if we do see NV, we have kind of 2 different flavors there, superficial and deep NV. Superficial is going to be more between the epi and Bowman's, whereas deep is going to be intrastromal. There's treatments, although you often have to start it immediately or before you have the NV, which is not really that helpful. Anti-inflammatories, steroids, anti-VEGF therapies, and then MMP inhibitors. And then for more mature NV, we have lasers, so argon laser. Sometimes, at least in my fellowship, we would treat patients with argon laser before we would do PKs because we don't want all those vessels coming into the cornea and then causing our PK to reject. One of the newer things is losartan, 0.8 milligrams per milliliter QAD for about 6 months. It's based more so on rabbit studies. It's anecdotal evidence. There's a lot of people that use it. I have a couple patients on it. You really have to have them on it for a long period of time to see any change. Some people have good luck with it. I think jury's still out on whether or not that is helpful. I think we're just desperate for an option for patients. So if there's anything that will help these scars without us having to do a PK, we reach for it. And then one of the things that's been talked about in the last 5 years or so, something called mitomycin, intravascular chemoembolization, where mitomycin is injected into these vessels. So the bevel is completely interstromal. You don't want to be in the AC. You don't want it to leak onto the surface. Use a 33 gauge TSK needle, which is tiny, tiny. And you want to hit those afferent and efferent vessels. So those juicy vessels that we see on the cornea are going to be efferent, but it needs enough force to go into the afferent too. So over time, you can get flattening of the cornea and improved astigmatism. So this is a really great technique, typically done at the slit lamp. And you can see in that video that really nice blanching of those vessels there. If you're interested in learning more about this, Dean Wano has a really great YouTube tutorial on how to do this. Okay, and then moving on into case 6. So this is a patient who has a double pterygium post-LASIK with a cataract. So we can see here that this is inducing about 7 diopters of astigmatism. And we can see flattening of the cornea here, 34 are his Ks here. So what do we do for pterygia? So medical, you can manage them medically with artificial tears, topical antihistamines, corticosteroids to reduce redness or improve inflammation, or you can address it surgically. You definitely want to address it if there's a regular astigmatism, the eye has good visual potential, and the goal is a toric or a premium lens. You want to take care to avoid dislodging the LASIK flap. You could use a crescent blade. It tends to be a little sharp. I tend to lean more for a Tux blade with these, especially if there's a LASIK flap. There's lots of different ways in how to remove pterygia. I tend to use a conjunctival autograft, and then I use MMC if it's recurrent. We'll skip over this video. Everyone has their own technique. There's perfect technique, there's rotational autografts, there's AMT, conjunctiva. We know conjunctiva has the lowest rate of recurrence. Okay, so this is a patient that has been through the ringer with her dry eye. She's tried all sorts of things and nothing is helping. So you take a look at her slit lamp exam and you see this little mini bump. You see this irregularity in her placido, some irregular astigmatism. What do we think this is? Close. This is anterior basement membrane dystrophy. But save that answer for like 5 minutes. So anterior basement membrane dystrophy is when we get extra sheets of basement membrane that extend abnormally into the corneal epithelium, which are our MAPs. And then these mature epithelial cells migrate toward the anterior surface of the epithelium, become entrapped in these extra sheets and form cysts. We also get these parallel or concentric lines of thickened basement membrane called fingerprints, which are a couple slides on what this looks like. Definitely want to use fluorescein on these patients because it can be subtle and you can miss it. There's management from medical to surgical. There's lubrication, punctal occlusion, muro before bedtime can be helpful just to smush that cornea together. Loteprednol and oral doxy. Surgical side, you could do a superficial keratectomy, do a stromal burr, PTK. You could consider stromal micropuncture. Only do stromal micropuncture if they have recurrent erosions. It's outside of the visual axis. You definitely don't want to be doing that in the visual axis. So I'm sure a lot of us do superficial keratectomies. You can do this in the OR, you can do this in the office. Can give patients Valium to help relax them, topical anesthetic, epithelial removal with a sponge, spatula, Tux, and scrape the base. Then you can burr it, do PTK or stromal puncture. PTK is done with an excimer laser. You remove the epithelium, use a masking agent, do a large spot size, then a very shallow depth. You can do MMC to prevent haze, put a bandaged contact lens on top of that, and then steroids and antibiotic. So this is a slit lamp photo of a patient at baseline, post-debridement, and post-cataract. So we can see clinically significant ABMD in picture A and B. 1 week after debridement and amniotic membrane placement, the ocular surface is healed without positive or negative staining in C and D, and then it did remain stable after cataract surgery in E and F. On the right side of your screen, A and B shows marked irregular astigmatism and a placido ring. C and D shows 1 month after treatment with reduced astigmatism from 6 diopters to 1 diopter, an improvement in the corneal curvature from 43 to 46 with change in that axis by 30 degrees, which hammers home that point in that if we'd miss this and we put a toric lens or a premium lens in, this patient's going to be very unhappy after and will likely need an IOL exchange. All right, moving on. So this is a patient who's motivated for glasses independence. They wear glasses full time, and you look at their cornea, and this is what you see. So what is this one? Yes, this is Saltzman nodule. So this usually occurs in middle-aged older women, often bilateral, slowly progressive. It's non-inflammatory. Kind of 2 flavors of this too. So we have an elevated and pannus-like tissue versus a deeper in Bowman's. So the elevated pannus-like tissue is easily separated. We typically don't need PK. It's actually very, very satisfying when you find that plane. You just kind of rip that guy right off. And some of these deeper ones, they're harder to remove, and you may need PTK, maybe a higher recurrence. So just something to keep in mind when you're discussing with these patients. I typically go a couple millimeters next to the nodules, find that plane, and then remove it. So you don't want to really go right on that bump. You want to go next to it. So moving on here, this is a tomography in a patient with Saltzman nodules. So this is the pre-op right and left eye with Saltzman's that's showing corneal flattening. We can appreciate that little blue area correlates to that nodule, demonstrating irregular astigmatism. This is the tomography after superficial keratectomy and PTK. So we can clearly see that that astigmatism has gone down to 0.6. It was 2 before, and we can see that that blue area in our anterior float is removed. And then again, here's our biometry. So we can see that we would have chosen not the correct IOL. We went from a 24 to a 21, and the axis has changed in the right eye. And then we went to a 23 to a 21 with no astigmatism correction in that left eye. Okay, so moving on. So this is a patient that's getting blurring in the morning that comes to you for a cataract consult. Complaining of glare when driving at night. You look at her cornea and this is what you see. What do we think this is? Yeah, this is Fuchs dystrophy. So Fuchs dystrophy is an autosomal dominant or recessive, symptomatic in the 5th or 6th decade, more common in women. Typically, what brings the patient into clinic is going to be a decrease in vision, contrast sensitivity glare. It's typically worse than awakening, decreased surface evaporation during sleep. It's typically asymmetric, although it is bilateral. And very end stage, you can get patients that come in with ruptured bullae and microcystic edema, but that's more so when the swelling has been going on for a long period of time. According to the eye bank, endothelial dystrophies, including Fuchs, were the most common indication for DSEC and DMEC. The next largest group were post-cataract surgery edema. However, a lot of patients with early Fuchs go undetected prior to cataract surgery, so the number of patients with Fuchs undergoing EK may actually be underreported. Definitely put that mag up on your slit lamp. It takes 2 seconds just to make sure you don't see any guttae before you take these patients back for cataract surgery. We have a couple options when dealing with Fuchs patients. We can either do a stage surgery, or we do the cataract first and then the transplant later, or we can do it at the same time. So we want to be thinking the cataract surgery first and only if there's a visually significant cataract, but there's only mild cornea changes, there's no edema, patient's not having any symptoms. You want to be thinking DMEC first and only if there's a no visually significant cataract, but visually significant or severe corneal disease, or if the patient has high refractive expectations and you plan to put astigmatism correcting lens. So combined, we want to be thinking they have a visually significant cataract, they have visually significant cornea disease, they're having morning blurring, and we're seeing edema. If you have an endothelial cell counter less than 1,000, or on your PACI, you're getting more than 640, that's usually my threshold. With the other cornea specialists in the room, do you have a threshold for your PACI? 620? Yeah. So you definitely want to be taking a look. If you have a pentacam, we'll say run on your pentacam. So just add that to your list of things that you're checking before cataract surgery. If the cornea is greater than 640, it suggests that the cornea is going to decompensate after intraocular surgery, cataract surgery. Okay, so some pearls if we're doing cataract alone. You want to consider cataract surgery a little earlier to avoid damage to those endothelial cells. Use dispersive OVD after every quadrant to protect those endothelial cells. Some people feel femto is helpful because this decreases endothelial damage. You want to leave the patient just slightly myopic if you're anticipating the need for DMEC in the future, because the DMEC will cause a very minor hyperopic shift. Use a low flow phaco energy, phaco away from the cornea, and maybe use some chopping maneuvers so you're not using as much energy. Okay, so if you're doing a combined phaco-DMEC, you want to limit the dilation during the phaco, which can be difficult, but you're going to have to constrict that pupil back down after you're done with the cataract in order to do your DMEC. Definitely trypan these patients. When you are operating on a patient with Fuchs dystrophy, the cornea will swell as you're operating and your view gets harder as time goes on. So you definitely want to do trypan just to help your visualization as best you can. Sometimes I'll actually pop it right out of the bag because I don't care too much if I'm damaging endothelial cells because I'm going to remove them anyway. And then I chop it and take it out that way. So that can be helpful since you then won't be operating in the bag itself. You don't want to make the capsulorhexis too big. Otherwise, when you're doing your unfolding maneuvers with DMEC, the IOL can actually kind of pop out of that capsulorhexis. So I usually go around 4.5 to 5 millimeters. Longer corneal incisions can also make graft adherence more problematic, and that can lead to decentered grafts. And then PI or dilate afterward, the miotic has an increased chance of error behind the iris. So this is a video of DMEC. So there's that graft going in. So the grafts are stained blue, and they're also stamped with either an F or an S based on where you're getting the cornea tissue. So after we insert it, we close the doors so that graft does not fly back out. Ask me how I know. And then we put a suture in the main wound. I won't make you guys watch me suture here. Oh. Okay. And then we're going to reform the anterior chamber, Goldilocks, not too much, not too little, and then we use a variety of tapping maneuvers in order to open up that graft. And then we're checking the stamp to make sure it's in the right orientation. If it's not in the right orientation, then we have to flip it and open it back up. After that's performed, we put a little gas bubble behind. Let's see, here we go. Here's our little gas bubble. Perfect. All right. So how about patients with Fuchs endothelial dystrophy, cataracts, and we want to be thinking more of a DSEC? So these are patients who have had tubes because the tube can cause the DMEC to dislocate, although there are plenty of surgeons that do DMEC in tube eyes. In patients that are aphakic, DSEC can be more helpful. You're not doing as much manipulation of the anterior chamber. Just remember, DSEC does have a greater hyperopic shift. You want to aim -75 or -0.5. The grafts are getting thinner and thinner. So first we want to measure the cornea here. I do a sub-Tenon's block for these. Some people will do retrobulbar blocks. Any of my cornea people doing Tenons, sub-Tenons? Retrobulbars? Yeah. Better tolerated. So we're removing our decimase. So I use a Fogla stripper for this. You can use a Reversinski. I like the Fogla. I score it twice and it tends to come off pretty easily. In Fuchs patients, sometimes in PBK patients, it's a little more adherent and a little more difficult. We're making our main wound and then we're removing that decimase. Then I use a bent needle. Here we're removing the viscoelastic that we put in. We don't want any viscoelastic when we're inserting the graft. Let's see if we can skip forward a little bit. Okay, so here I've inserted my Busin Glide, although there are companies that do preloaded DSECs. You can definitely do that too, nothing wrong with that. Here I am removing the tissue. We're removing that graft. And then we place it endo side down on a little dot of viscoelastic, and then I take my bent needle and I just push that guy in. You can then remove your glide. Here we go. And then you can put a suture in the main wound, and then we put a little bubble behind that. I tend to have the patients lay flat in the post-op area for about 2 to 3 hours. I then recheck them, make sure that it's still attached, especially in patients that have tubes. Sometimes that tube would just eat the bubble. So I've definitely had to go back to the OR and just added another bubble because it is very important during those first couple hours that you have good adhesion. Okay. All right, and then just of note, you want to avoid hydrophilic or multifocal IOLs in patients with Fuchs. The gas used during DMEC can cause a hydroxyapatite deposition down the line, and the lens would have to be removed. Be careful in presbyopia correcting lenses. Not that you can't use them, but you have to chat with the patients about possible decrease in their clarity. They have higher corneal, higher order aberrations, as well as an increase in their objective scatter index. We can see that that top bar is in Fuchs patients, whereas the normal is in red. There has been some discussion of the role for LAL in these patients, which we can revisit in a minute. So Let's see if I can get through some of these last few slides. So patients with prior corneal surgery. So this is a patient PKP after trauma, corneal edema, 2+NS. Hey, was surgery going to help? In these patients, you want to be thinking, what's the risk of their graft failure? What's their astigmatism look like? What's their prior reason for a PK? Is it herpes, keratitis? You want to make sure that's under control before you're considering touching that cornea. What does the graft look like? What's the corneal thickness and the clarity? What's their astigmatism? Surgical pearls, if you're going to do astigmatism correction, what some people do, you want to do a toric lens only if it's regular and stable for many years. I don't tend to do torics just in case I have to replace the graft, but if somebody's been stable for many, many years, it is something that you can do. I wouldn't necessarily do relaxing incisions, but I have seen some people do it. You want to make sure you're doing it inside the graft-host junction. Use Trypan during these cases, use dispersive, minimal stromal hydration because you don't want to open up that graft-host junction. You always suture the main wound, and then there's nothing wrong with doing a scleral tunnel in these patients. The Trypan, again, extra important. It's like looking through a funhouse mirror when you're doing cataracts through PK eyes. Let me just go back here. So this is a patient actually that came in wanting his cataract removed, and I ended up just doing a DSEC under his PK, and he did great. He's 20/30, so we can hold on cataract surgery for a bit in this patient. Okay, this is a 75-year-old female with previous RK looking for glasses independence after cataract surgery. So the hardest part with these patients is finding the Ks. So RK is going to flatten both the anterior posterior curvature of the cornea, but in a very small central optical zone, and this can actually change throughout the day. So you can get fluctuation with these patients, and patients that want LALs, sometimes we have them come in at the same time or when they like their vision the best, and that's when you're doing the correction. But these patients require chair time. They're not going to get perfect vision. You make them 20 happy. They have some irregular astigmatism. You have to tell these patients that their irregular astigmatism is not going to go away with cataract surgery. Try to get a variety of Ks to try to pick the best ones. Some surgical pearls, less than 8 cuts. You can go in between the RK cuts. Don't intersect them, or you're going to be suturing for a while. Greater than 8 cuts, consider doing a scleral tunnel. Low flow, bottle height, suture the main wound. Sidel with fluorescein at the end, just so you can sleep at night. And then with LALs, they can get early post-op hyperopia. So wait to give them prescriptions. And when you're doing the LALs, I usually will wait sometimes 2 to 3 months. So this is a patient who have had LASIK. Previous myopic LASIK, high expectations after cataract surgery, and they want to be glasses independent. So there's calculators that are available, ASCRS IOL power calculator, there's Aura, if anyone's using Aura. These patients I think are great for LAL because some of the formulas are not as accurate, so you can really fine tune these patients, especially if they have higher refractive need. You want to neutralize their spherical aberrations, so with hyperopic LASIK, they have more of a negative spherical aberration, use an aberration-free lens, whereas in myopic, they have more positive. Best to use a negative spherical aberration lens. Am I doing it on time? So keratoconus, so this is a patient, keratoconus, has had cross-linking, stable, they're in sclerals. These patients can be a little difficult with refractive planning as well. A lot of our formulas assume normal eyes, and these patients do not have normal eyes, so we often result in hyperopic refractive surprise, so consider making these patients a little more myopic. Stop their contact lenses, gas perm or soft contacts, soft torics out for at least a month. Soft, you want to be off for a week. I typically get 2 visits with agreement in their topos. Because you want to make sure those corneas have totally unmolded and are stable. I like to use the EKR on the pentacams. You're looking at different diameters to help you choose what kind of lens you're going to put in the eye. If their vision is worse than 20/40 and a contact lens, you could consider doing a PK prior to cataract. Again, patient counseling. So lens options. Torics, do they have a very stable cone? You could tell them that it's going to debulk it. It's not going to eliminate it. You want to be careful in patients that are already in hard contact lenses. Their vision is not going to be the same after cataract surgery as in a hard contact lens. The hard contact lenses, scleral contact lenses, are really going to give those patients the best vision. IC8 is off-label, pinhole optics, usually using the non-dominant eye. I'll have patients hold up their pinholes to make sure that they are happy and okay with the decrease in contrast and the decreased peripheral vision that they may get with that lens. But it does work quite well in these patients. And then some people will do LALs It only corrects up to 3 diopters of SIL. It does need a larger incision for the lens injection. Larger incisions in keratoconus patients can be harder to close. They may need a suture, and it's going to take a lot of time to stabilize. All right, I think for the sake of time, we can skip this. Okay, so intraoperative. Main corneal incision, or consider just doing a scleral tunnel in these patients. Use your trypan. Dispersive OVD will magnify, and that can be helpful. Low flow settings, and then you want to monitor for astigmatism progression after. Consider an IOL exchange or piggyback if you have a refractive miss. Does anyone here use Veracity? Yeah, Veracity has been great in some of these more complex patients. We can load what your favorite lenses are, and then you can pick what your target is in the software, and it compares all the lenses. Compares all the formulas, which I really like it for. You can add your IOL master, you can add your Pentacam, you can add your EKRs, and you can really compare across different formulas and different Ks and what the best lens for that patient's going to be. So I've definitely love this software. It takes a lot of the guesswork out of it. Okay, so this is a little bit about Band K. I'm kind of running low on time, so I'm just going to kind of go to the end here. So with Band K, there's 2 options for this. There's K2 EDTA chelation, or there's EDTA chelation. You can actually use the little blood tubes for K2 EDTA chelation, and you can do that right in the office. Can be helpful. EDTA works just fine. This picture I really like because you can see these little holes in the Band K, which is actually the corneal nerves. So keep a look at that next time you see Band K. Corneal scars. So patients with corneal scars can be a little tricky. You want to kind of determine how deep the scars are, how much irregular astigmatism, what their visual potential is, and what the red reflex is going to look like when you're under the microscope. If they're more superficial, you could consider doing PTK and then just treat them as a post-refractive. Or do we consider actually improving the scar before cataract surgery? Do we do an open sky cataract with a PK? Do we do a DALK? Do we stage it? You want to consider using IOL calcs in the fellow eye and tell them they may need an RGP or a scleral. You could pre-trial with the contact lens, and there may be a role for IC8 in these patients as well. If you decide to just do phaco alone, some things to consider with patients with corneal scars. The view into the AC, if the red reflex is adequate, use trypan in these patients. Can tilt the eye to complete your capsulorhexis. That can be helpful. Don't operate in the bag. Bring those pieces up and away with the chopper to stay away from the posterior capsule, and take the eye out of primary gaze for visualization. I really like the Coach spatula for this, because I can kind of take those pieces, bring them up, and that also protects my posterior capsule. Lighting is a big thing with these patients. We use coaxial lighting, which causes a lot of light scatter or glare. So in order to bypass the whiteout effect, you can use transcorneal illumination. You place a light pipe at the limbus at about a 45-degree angle, 25 or 27 gauge, and that off-axis lighting minimizes the reflections from the scar, which can be helpful. Or the chandelier technique, which is endoillumination, which you can ask your retina friends about to help you with those cases. This is something that's really cool. This may be the future here. So this is a new lens, or new microscope that integrates visible and infrared illumination that penetrates dense cataracts, cloudy corneas, and helps deliver clarity, depth perception, and safety during surgery. So this may be the future, operating under these infrared conditions. So we can see them making the capsulorhexis here. Okay. And then this is something new that I had never seen before, so I wanted to end with this. So I'm in Jersey, so there's a doctor in Manhattan that does a lot of this. So this is called FLAX, or femto laser aesthetic annular keratopigmentation. Has anyone seen a patient with this? Yeah, a couple people. Yeah, so this is a procedure where they're using a needle or a laser to create space in the cornea using colored pigment that's injected that permanently changes the cornea from clear to opaque, covering over the natural iris color. There's risks associated with this. It's very popular in social media. When I first saw this, I went on social media, and there's a ton of patients talking about their eye color change surgery. The patient that I saw came in for photophobia that was persistent after this procedure. There's risks associated with this: warpage, fluid leakage, vision loss. Sometimes the pigment actually travels. And on social media, you see these small images where you really can't see the detail of the cornea. So I took a picture under the slit lamp, and this is what it actually looks like. So doing cataract surgery in these patients in 10, 20 years, I think we may be needing to use that infrared system, because these are going to be very hard to do cataract surgery through. All right, so these are my references. Thank you for having me. If you need to get in touch with me, these are good ways. And this is my son, Theo, helping me make this presentation today. Any questions? Yes.
Could you walk us through this EDTA blood collection treatment?
Like the serum tears? Or EDTA chelation for band for band? Yeah, so there are quite a few steps involved, but basically it's using saline in the blood tubes in order to make your own solution, and then doing it the same way as you would EDTA. So you put it on a little sponge, do your superficial keratectomy, put it on the band K, and it dissolves that calcium really nice. And I think a little quicker, actually, than EDTA. I don't know, are any of my cornea people doing K2D? Yeah. Dean Wano, again, he has a great video on how to do this and adopt it in your clinic. And it's pretty quick. It works really well and is a great low cost, effective way to treat band K. Sometimes surgery centers, at least in the last year, we're having a little difficulty getting the EDTA, so this is a good option. And you go down, if you're at a hospital, go down to the lab, and oftentimes they'll just give you the purple tubes for free. Yeah.
So if you have a patient that's like cataract surgery and they're moderate Fuchs dystrophy and their pack temperature is like 600, what should we target? We don't know if they're going to do a DMAC or a DSAC.
Yeah.
I mean, should we target planners? Should we target -75?
I would say like minus 0.5 is probably safe. Yeah, I think most people will do DMAC, unless they're if they're going to definitely be a DSAC eye, like they have a tube or it's like a very unhealthy eye, you could target more toward minus 75. But the DSACs are getting thinner and thinner, so I think if you target like a minus 0.5, you're safe for both. What would you say? Probably, is that what you usually have people target? Yeah. Yeah. And then just use lots of viscoelastic, and then you may never have to send them to your cornea surgeon anyway. Yes.
Two questions. On your pterygium patients, how long do you wait to get your biometry to do your cataract surgery? The same thing with your ABMD patients?
I usually wait 3 months. And I tell them it's going to be a minimum of 3 months, sometimes longer. I'll get my first set of IOL measurements, do their pentacams, and then I'll repeat it a couple weeks later. If I see that it's consistent, then we can go to the OR. If they're still changing, then I wait longer. Yeah.
Also for ABMD, same thing?
Same thing. Yeah, same thing. Yep.
So my question is twofold. When I first started about 10 years ago, I did a couple of cases of superficial keratectomy.
Yeah.
And it, I found it forward. So is it not recommended to do SK without CTK now? And then my other question is, I've been lately just sending them to cornea specialists, so I'm wondering if comprehensive ophthalmologists are doing
Yeah, so you can definitely do superficial keratectomy without PTK. I will do that all the time, especially for ABMD that doesn't have, it's not deep. You could use AMT with those patients. Definitely want to ask about keratitis history. I have definitely had one case of that where this patient got geographic ulcer after. I had to put her on oxervate, and definitely don't want to go down that road. So there is a risk associated with superficial keratectomy, even though the procedure is pretty easy. I think that the comprehensive ophthalmologist can do superficial keratectomies. I think especially for ABMD, Saltzman nodules kind of depends on your comfortability. I do tend to take Saltzman nodules to the operating room just because I feel more comfortable under the scope in those, because sometimes it can take a little more pulling to actually remove those nodules, and having a patient sit still in a slit lamp while I'm doing that is a little tougher. But yeah, I definitely think the comprehensive ophthalmologist can do super Ks. Just follow them closely. I'll do AMT, then a bandage contact lens. Consider seeing them like a couple days after, especially if you use the dehydrated AMT. Take the contact lens off and take a look at their surface and kind of see how they're doing. I would also see them back if you're first starting this, maybe a week after and then a month after, just to follow them closely. Anything else? All right. Thank you.
I'm just gonna have a clicker right here. This is your next back. You have a laser pointer here. Forward, back. And it'll just be right up here. And then you don't have to do anything with this. It's on. As long as this green light's on, you don't have to touch the screen. So that's your lens view right there. And then, yeah, I have your.
Hi there, everyone. Hi there. I think we're going to go ahead and get started with the next speaker. All right, I've got Dr. Nathan Kenyinda here today to talk about ophthalmology and to talk about oculoplastics for the generalist. Dr. Kenyinda is a board-certified ophthalmologist who's fellowship trained in oculoplastic surgery. He graduated among top of his class at the University of New Mexico School of Medicine. He received academic honors as well as a nomination to the prestigious Alpha Omega Alpha Honor Society. His internship was at the University of Hawaii, and he did his residency at Howard University Hospital and VA Medical Centers in Washington, D.C., as well as Orlando, Florida. And he received his fellowship training from the University of New Mexico, Albuquerque. So please welcome Dr. Kenyinda.
All right, so thanks for having me today. I'm actually based here in Phoenix, so if you guys haven't experienced weather like this, welcome. And it's a good time of year. You guys beat right before we hit the June, July timeframe. So today we're going to talk about oculofacial aesthetics for the generalists. I think that even if you're not looking to get into aesthetics, it's important as ophthalmologists to know and have some general baseline information, because with TikTok, Instagram, all these things are trending, and a lot of aesthetics revolves around the periorbital area, and so it's important for us to know. As mentioned, my practice mostly focuses on the typical oculoplastics stuff, lacrimal, orbital, eyelid reconstruction, but I do a lot of aesthetic medicine as well, and I find that especially in the world of oculoplastics, if you're not doing cataract surgery, you got to keep yourself busy with some aesthetics and cosmetic. As far as I have no financial disclosures, and then some of the topics we're going to talk about do include non-FDA approved uses. So I had published an article where I discussed uses in Botox in eye care. It's important to know that ophthalmologists ophthalmology was the first, or one of the first, to use Botox in a clinical setting, and so that's a fact a lot of people don't know. But Botox in ophthalmology has played a big role since the beginning. Now, we're going to talk about several different things, and I'll try to move through this so that a lot of times some of these topics may be new for some, and it may be a little bit overwhelming, but I'll try to keep it very general, but also useful information. I do think that for a general ophthalmologist, or in general, I do think that it's beneficial to know how to use your practice, if you can, and shift to an aesthetic space. I think there are a lot of people doing aesthetics right now around the eyes that maybe shouldn't be doing it. People injecting different things, and a lot of times as ophthalmologists, we stay silent. We don't say much. So it's important for us to know what's going on. So we have different topics that we'll touch on. First topic is going to be the biology of facial aging. So it's important to know that as we age, we start to go through a process of bone resorption. The inferior lateral rim is where we start to see that early on, maybe around the 40s, and then we start to see this expansion of the socket and elongation of the socket. So as the bony structural support, or we have an expanding orbit, as that occurs, we start to see that some of the changes that we note in the face also start to happen around that. So it's important to know that this is an important part of aging, and you may start to see some changes around the septum, changes around the skin, laxity, the cheek, the tear cheek or the tear trough, and so it's important to know this. As far as we talked about cheek descent, we talked about facial changes. The eyelid skin is very thin, so this is one of the areas where people will notice aging changes the most. I have so many messages and DMs, and people say, can you help me? I don't know what to do about my dark circles. I don't know what to do about my under eye bags. So it's something that comes up a lot. And the reality is that the skin around the eyelids is very thin, so less than a millimeter thick. And so this is important to know, because as we talk about treatments, as we talk about things that we can inject or things that we can use for lasers and all of that, the thin skin that we have in the eyelid, it does make a difference. Also, as we age, that thin skin also can affect the appearance of the eyelid. Now, I deal with a lot of droopy eyelids, ptosis. That keeps my practice pretty busy. So we're well aware of that, and we're also well aware of fat herniation in the lower fat pads. And a lot of times fat herniation comes from changes in the septum and the structural support that occur. But these are common things that we see when people start to age. The change in face shape. So I've noticed that a lot of patients will come in and they'll have a photo of a celebrity, and they'll say, can you make me look like this person? And oftentimes I say, I can't make you look like George Clooney. I can't make you look like Denzel. I can make you look like a more enhanced version of whatever your baseline, but the face shape is an important consideration when we're thinking about facial rejuvenation. And so we say that younger folks will tend to have a heart shape, and then as we get older, we say that the face starts to develop almost a square sort of shape. And we know that UV light, sun exposure, is one of the biggest accelerators of aging, and so that's why we promote sunscreen for everyone. We also know that oxidative stress, so sleep, poor diet, fatigue, these things can also cause changes that are age-related. Repetitive movement, so a lot of times when patients come in for Botox, they'll frown or raise their brow. Sometimes I have family and friends that will say, "Do you think I need Botox?" And I'll say, "Raise your brow," and they'll have all these, their forehead lines. And so essentially, when we say Botox is preventative, we're saying that we're taking what are dynamic lines, right? So lines that are present when we have repetitive movements that may eventually become static lines, right? So, and so when we start the process of calling this preventative, we're saying that if we relax these actions, we can reduce that incidence of that. And so blinking, smiling, and some patients like it, right? It's not saying that everyone wants to get their crow's feet treated. Some people really like their crow's feet. Some patients will say, "Hey, this gives me character." So it's just subjective, but we also know that repetitive movement can, in fact, cause some changes related to aging. Now, there are differences between men and women in terms of considerations with aging. Men tend to have a brow that's right at the rim and more horizontal. So when I'm doing a brow lift in the man, I'm making sure not to give him an arched brow. So that's very, very important. And with women, it's different, right? Their brow sits slightly above the rim, and they tend to like that arched brow. And in general, the jawline of a man will tend to have less resorption. So men will tend to develop to maintain that structural integrity there. Women are more likely to have some descent of their mid-face earlier than men would. And so you see earlier atrophy of the SOOF, suborbicular oculi fat, and you see some tear trough hollowing. You can see some people, not everybody has the Hollywood magic where they can age this well, but I think being aware of some of the changes that a patient may come and say, this is what I'm worried about, and understanding that there are some gender differences, and this is just a general concept. Now, by age, when we look at patients who are coming in their 20s and 30s, we're talking about essentially just prevention, pre-rejuvenation. We're talking about skin care. Eyelid skin care is something that's people don't understand it. So the amount of money people spend on eye creams is a little bit crazy because they don't understand it. And they're throwing all this money at eye creams and they don't understand. Now, some providers also don't understand it. So they'll say, well, don't use any eye creams. And so what we have to understand is the eyelid skin is still skin. And so although there are limitations, eye creams have limitations. They're not going to treat fat prolapse. They're not going to treat a lot of specific issues. If you're talking about general skin care, there are certain ingredients that if they're going to use the eye creams, you should be able to know and tell them this would be most beneficial. 20s, 30s, we're going to look at light laser resurfacing, maybe perhaps a preventative Botox. When we get into the 40s and 50s, we're starting to look more into volumization. We're seeing changes in the structural support of the face. We're seeing some mid-face fat loss. We're also seeing injectables in this age range. And this is generally the time frame where a lot of patients start to come and realize, wow, I don't look like how I looked in my 20s. I need to do something. And so they come around this time frame. When we get to the 60s plus, typically we're talking about some kind of surgery. And I tell patients, I'm sorry, I know you've gone to this med spa, you've gone here, you've gone there, but you need a facelift. That's the one. That's what you need, or you need to have a blepharoplasty. Patients will often get a Botox, a brow lift, and they'll say, I don't understand why my Botox brow lift isn't working. Well, you have a lot of dermatochalasis, and so it's just you've aged, and with time, it's important to recognize some of these things. As far as the Fitzpatrick score, so this is an important main sort of a core concept in aesthetic medicine. And because as ophthalmologists we use IPLs, because we also are involved in some capacity in either directly, treating skin or indirectly in some way, it's important to understand the Fitzpatrick score. So a type 1 is going to be that person who always sunburns and, if they're out in the sun too long and they never tan, right? So the type 5 might be the person who rarely sunburns, but they tan very often, frequently, and they're just essentially they're tan. So and there's a range there, and a lot of times this can be affected by ethnicity in terms of, so you might see a patient, they might look like a 2 or a 3, and then you start getting into their family background, and you realize, oh, okay, well, you have some family that comes from here, you have that, and sometimes we've seen that can affect how they respond to the laser, even though they may look like a 3, they may be responding like a 4, and so there are questionnaires that exist that can help ask these questions. If you have a practice where there are a lot of patients who are a diverse practice, maybe you have Hispanics, Middle Eastern, Asian, Filipino, you might want to start looking into options, especially if you're treating dry eyes, right? Because IPL, as we'll mention later, may not be a great option for people who are in the higher Fitzpatrick scores, right? And so we want to be able to offer a broad spectrum of options for our patients. And so this is something to get familiar with and to know. Typically, it's ranging from 1 to 6, and it's very helpful in terms of safety when we're talking about energy-based devices. So anatomy and mid-face safety. So anatomy is important. So for students here, every time I'm going into a case, if I'm doing a Mohs reconstruction or if I'm doing some kind of procedure where I have to consider there's an anterior lamella, the septum, and the posterior lamella. So I'm always thinking about this. And when you think about the anterior lamella, in a Mohs reconstruction, I just did one yesterday, and I had to reconstruct both the anterior lamella, and I had to come up with something for the posterior lamella. And they're very different, and knowing the anatomy, the general anatomy of the eyelid, is very helpful in terms of knowing how the function of the lid, understanding the depth, even when you're doing functional Botox, right? Understanding how where to place the Botox. In some patients, you may be in an area where there's not a lot of oculoplastics, and you might have to be the one doing the hemifacial spasm or even blepharospasm. In the article I wrote, I talk about that it's an easy entry point for ophthalmology into the world of aesthetics because we already have functional reasons to use some of these things. Now, when we talk about the anatomy around the eyes, we talk about, we can see that we have the malar septum. So this is an important point, and you see that photo there. We're looking at the orbicularis, we're looking at the malar septum, we're looking at the SOOF. And this is important because where people inject filler can impact what their outcome is going to be in terms of complications, right? So if someone injects too superficial versus if they inject too deep, this is where we can get some complications. And that malar septum serves as almost an impermeable barrier that allows, that essentially, let's say you're bruised or there's fluid, it almost separates the lid and the cheek, essentially from having extension of that fluid down to the lower face. And so it's an important barrier. And it's important for us to know at least the general concept of the ligaments that affect the area around the eyes and the cheek. And I always say that if you're going to do periorbital aesthetics, you have to understand the cheek as well, because the cheek is an important part of the periorbital region. So essentially, you talked about impermeable fascial membrane that essentially originates from the orbital rim periosteum, and then it inserts into the cheek skin. So very important to know that. They looked at this critical landmark that divided the cheek into fluid compartments. And so the clinical significance is essentially, as I mentioned, it prevents fluid from draining downward. And we're going to look at some examples of how this can play a role. Now, you have patients that come in, they may have malar edema and festoons. So these are the patients that they're confused. They don't understand why they have the under eye bags. Say, I don't have a lot of fat here, but if you look right here in the cheek, there's a little fluid pocket. Some people may have it in this room. And a lot of times patients who have that edema, it often recurs, and we don't want those types of patients to just go and get filler from just anyone, right? We don't want them to get certain procedures around the face and not from someone who doesn't understand the anatomy. Eventually, malar edema can become a mound or malar mounds, and then we can have something what we call festoons. Festoons are sort of the bane of my existence in oculoplastics because whenever you see it, whenever you see someone with malar edema, and you're about to go into a lower lid bleph, they have to understand that the treatment of both are different, right? So in fact, a lower lid bleph can worsen malar edema if you're not careful. So if you're a novice, you're just going in, you did a lower lid bleph, you think you did a great job, and now they're there and they have this persistent edema, you have to kind of counsel them that, hey, the way we need to treat this may be a little different, or you can do an extended blepharoplasty, and there's just different ways surgically that you can manage that. But from a medical perspective, from a general ophthalmologist perspective, this is something that may come up, and you may even notice in patients. This is a photo showing that progression from malar edema to the level where it can become a malar mound and where we can get to the point where we have festoons. And there are ways that we can treat this. In the context of this conversation, filler, if injected in the wrong location, can cause obstruction of the lymphatics, which is a big part of the pathophys of malar edema, festoons. And so it's important that we understand that if you're injecting superficial to the malar septum, this can create a mechanical obstruction, further compressing the lymphatic channels. And so hyaluronic acid is hydrophilic, so it attracts water, and it's important to know that. And so when trapped against the septum, the hyaluronic acid can cause that fluid accumulation. And so a patient may come, and this is why with time, a lot of us have been more and more careful with filler, not just because of the findings we're finding in the periorbital area, but also just because filler migrates, right? We have when we smile, when we have the orbicularis action, that pumping action, also can cause filler to move. And in general, a lot of patients aren't aware that their filler can especially migrate around the eyes and around the cheek. And so when we inject around the cheek area, we want to make sure that we're in the pre-periosteal location. Now, we talked about ways of trying to prevent that in patients. It's important to know that if we're in a situation where someone comes and they have a complication such as malar edema from filler, we do have hyaluronidase that can dissolve the filler, and it does make a difference. And so this is something that I tell patients even before we do a lower lid blepharoplasty, before we even go into surgery. I let them know, hey, if it's possible to dissolve that filler, because filler, going into a lower lid bleph with filler there is not, it's not an ideal situation for us. And then also patients may be concerned about that area. So not just learning about the filler, but also learning about how to dissolve the filler, how to treat that is very important too. And so just to be familiar with it, you may have heard about it, you may have not, but it's something that's important to know. As far as the reality of filler migration, I talked about the pump mechanism around the eye and how filler, in the beginning, when we used to do a lot of tear trough filler, there was sort of this teaching that if you go deep enough, you should be okay. But we're finding that if you imagine the amount of people who are out here injecting tear trough filler and the amount of patients who may not be candidates, we're finding that it's become a problem, and a lot of oculoplastic surgeons have, some still do it, some others don't do it as much, but you're finding that a lot of people are starting to perhaps back away from filler, or specifically in the tear trough for these reasons. We'll talk about other options, but this is something that I have done less, and I don't really do much anymore just because of the potential complications. And even if you do it right, there are a lot of people who aren't great candidates. So I don't think it's so much that filler is bad. Some people want to paint that filler is this bad thing. Filler actually can be useful in the right areas, but I think it's more so that there are so many considerations in that tear trough area and in the lid that it's important to consider that not everyone may be a great candidate. The Tyndall effect, so you can have sort of a bluish appearance because of the lid skin is so thin. So if you inject too superficially, that can be present for long after you've used the filler. And in general, when we look at filler migration, that can occur with any place that you inject it. I would advise that if you are going to counsel patients on tear trough filler, I would 100% advise them, number one, not to go with just an NP or somebody in a med spa that's offering to inject that in their lower lids, because most likely they don't understand enough about the anatomy. Number two, I would counsel them that there are other options that exist besides hyaluronic acid filler. And I would also look at their anatomy and let them know that a lot of patients have allergies and they have all these different things that predispose them to malar edema, that predispose them to, as they say, I wake up in the morning and I feel like my eyelids are puffy. Those aren't patients that should be getting filler, but think about how many of these patients have allergies, how many of these patients have these issues. And so when you start to think about it, it starts to pull you away from the idea of convincing them or encouraging them to do tear trough filler. Now, the placement, I love cheek filler. I still think this, it makes a big difference. I think it's a great alternative. And I do think that when injected in the right way, and it's a lot easier to inject around the cheek, I do think that can also improve and enhance that periorbital area. This is another photo here showing malar edema. And again, due to migration and lymphatic blockage, direct tear trough filler has created variable results. And yeah, I mean, I don't think there's much, I don't want to belabor this point, but as you counsel patients, I would kind of let them know that there are a lot of mechanisms that can impact their outcome. They may, a lot of times online, you'll see people show results that are amazing, but it's right after they had the filler. A lot of times, even with facelifts, even with different surgeries, you'll see patients show, well, these are my results, but what about 3 months down the road? What about 6 months down the road, a year down the road? And so that's what we're thinking about as clinicians, as physicians. We're thinking about, okay, what are going to be the long-term effects of these treatments? Now, we talked about Hylenex, that's an option, but what about people who have malar mounds, malar edema, and what are some medical treatments that have been known to be effective for these patients? So it's important to at least also be aware of this. So oral tetracyclines are effective. Diuretics, I've never used or prescribed diuretics for a patient, but it's essentially, it helps with the fluid issue. And then injected doxy, sclerotherapy. That is something, for different reasons than the oral doxy, the injected doxy can cause a chemical irritation that can essentially work on the lymphatics and that malar mound and help to reduce the incidence of it. So it's important to understand these things, and although you may not be injecting or doing doxysclerotherapy, you can prescribe doxy, low-dose doxy to help with that. We also have laser as an option. So in my office, I have a Morpheus, I have a CO2 laser, and the CO2 laser is sort of still the gold standard. A lot of times in the world of aesthetic medicine, people will have these trends, right? So you'll see things that were popular 15 years ago, then people forgot about it, now they're popular again because of some TikTok. Then you'll see something that was, people have been doing CO2 forever, but people will come into my clinic and act like it just came out, right? They'll say, oh, wow, I heard about this, or I heard about CO2 laser, and what's true, though, is when something is effective and when something works, it's going to sort of last and fight the test of time. And CO2 laser has done that. And so from a clinical perspective, having it in an oculoplastic practice, having it if you accelerate or you extend an aesthetic practice, I think CO2 is an important area for ophthalmologists to understand as well, because you're going to have patients who may be getting CO2 laser from other providers, and they come into the clinic and they may have complications. So someone comes in, they have HSV, and you find out in their history that, oh, you just got a CO2 laser. They weren't properly prepped for it, and this is a complication that can occur if you're not screening and you don't understand who's a good candidate or which candidates need to have prophylaxis. And so the CO2 laser in the case of malar edema is pretty effective. This is a patient that I treated. You can see before she had all this lid edema, and we did just one round of CO2 laser, and that was enough to treat her malar edema. So it does work. It is effective, and I do recommend that we'll talk about the tiers of how to get into aesthetics as a generalist, but that is something to consider at some point, some sort of resurfacing device down the road. Now, with Botox, I'm not going to talk about reconstitution too much. We'll just kind of talk about the general sense. But I do a 1-to-1 around the periorbit. High concentration doesn't diffuse as much. Some people like 2.5 to 1. That's good for certain areas like the forehead. But I like a 1-to-1 reconstitution. And just to kind of give you an idea with Botox, there are different neuromodulators. And there are different options. When I do functional injection, I usually use Xeomin, and these prices can vary and change, but typically Xeomin costs me less to obtain, and I find that if I'm doing a functional hemifacial spasm or blepharospasm, it makes more sense to go with Xeomin. Xeomin and Botox are essentially where you inject them, that's where they're going to be. Dysport can spread, so sometimes I've seen patients who come in with ptosis secondary to neuromodulator injection, and oftentimes I've seen it could be any of them, but I've seen it be Dysport injected too low, just above the brow, and it diffuses down, and it can cause a ptosis. You can treat that sometimes with Upneek if they can respond to that, if that ever occurs. There are also ways that we can inject from the oculoplastic side to kind of reverse that. But typically, patients, there are different options for this. And so if you familiarize yourself with that, you don't have to just, patients hear about Botox. It's a household name, so that's what they want. But sometimes there are other options, right? And if it's more cost effective to go with one and it works, at the end of the day, it's more about the pattern than the product or even the amount that you do. And there are different courses, different ways to learn. I recommend as ophthalmologists, if you want to start with patients who are functional patients, hemifacial spasm, blepharospasms, it's a good way to sort of get into it. And as far as the benefits, pros and cons of each, you'll see Daxxify, Dysport will start to take effect sooner. And usually I tell patients, give it about a week, 1 to 2 weeks depending on the patient. Usually within a week, patients will see a difference. Daxxify, Dysport, they do see a difference a lot faster. And Daxxify has sort of this, they're basically essentially they're known for lasting 6 to 9 months. When we've done studies, we've seen that some patients, even with Botox, have lasted up to 6 months as well. But Daxxify has sort of this reputation that in some patients it can last longer. And so there are different products that you can use, and if you familiarize yourself with them, it could be helpful as well. I talked about sort of what I do. I use an insulin needle. It's more comfortable for the patient, and it's perfect for a 1-to-1 ratio. If you do a different ratio or 2:5, you may want to use a different syringe. As far as the areas that we treat, as ophthalmologists, we will treat a lot of Botox treatment is going to be around the periorbital area. And so that's why I think it's kind of an interesting thing that so many people, when they come to me for Botox and they ask me, hey, do you, as ophthalmologists, do you guys do Botox? I let them know that, hey, we inject our anatomy. Most of this anatomy is in the periorbital area. right? And if something goes wrong or something happens, we have to be the ones to know what to do or how to fix it. Patients who have heavy lids or they have excess skin, it's important to counsel them that you probably do not want to get heavy Botox on your forehead. That's going to relax your forehead too much, and you're going to feel like your lids are heavy. And some patients, as basic as that sounds, as simple as that sounds, some patients don't connect the two. So it's important to counsel patients on that. Another thing that can be helpful in a patient that's in that situation is a Botox brow lift. It's very effective. You do a little bit of Botox at the tail end of the brow. You do a little bit of Botox in the 11 lines, and that helps with elevation of that brow, and it can be helpful in some of these patients. And so this is just a general chart showing all the areas that we can inject. And what I love most about oculoplastics is that the knowledge that we have of eyelid anatomy, the knowledge we have of the periorbital area really allows us to give patients excellent feedback on what would work for them, and while still maintaining appropriate lid function for them. We talked about some important things to know as far as safety. When we inject around the orbicularis and we're doing crow's feet, it's important not to affect it. If you go too low on the arc here and you inject in the zygomaticus major, you could affect the smiling. I've never seen that happen, but you want to try to stay sort of a reasonable distance, and different people have different sizes of their orbicularis, but usually I just have people smile. I have people frown, raise their brow, and you can kind of see their anatomy a lot easier, and it's really custom. And so as you get more into it, as you potentially take a course or learn a little bit more about Botox and injecting, you start to see that there are a lot of small considerations here. Lower lid dosing. So some patients will come after a lower lid bleph and they'll say, okay, so I had the fat pad removed. It looks better, but when I smile, I see a bulge. And some patients are confused. Well, and usually in the pre-op or before the surgery, I'll talk to them and say, hey, when you smile, a lower lid bleph cannot fix that that orbicularis, that bulge that comes from that. And so Botox can be used to treat that, but I would be very careful. So a lot of people aren't out there who are injecting, they're not doing snapback tests. They're not thinking about lid laxity. You do not want to inject even a couple units of Botox in a patient that has a poor snapback test. But that patient who has a reasonable snapback test that's worried about what we call the jelly roll, so when they smile, we call that the jelly roll, and a little bit of Botox in that area can help alleviate that. It's also important to let them know that a lower lid bleph will not fix that. And so for us to know that and being able to counsel them if they ask us any questions regarding that matter. This is a general dosage map. And what I always say that if you're going to learn Botox and you're going to learn how to inject, we all have staff. The people who are going to be most excited are going to be your staff. They're going to line up. They're going to be, so, every time we get a new product, I don't know how many times I'm staying late just injecting, but it's a great way. Typically, what I tell folks is you get a rep to come in, you sort of learn about the product, kind of commit to it, then you have a training day, have some of your staff volunteer, and just you sort of train and learn with the staff there. It's a safe environment. It's not scary. They understand what's going on, and it's a good way to sort of learn or get into the world of Botox or neuromodulators. I also think that injecting around the eyes is a good place to learn. You don't have to go and do Botox injections in other aspects of the face. You can just start where you're comfortable and then move further from there. And because so many of the areas that we inject Botox, as I mentioned, are around the eyes, it's a perfect place for a generalist or an ophthalmologist to get into it. And there are urologists out there doing, they're injecting in these areas. So there's no reason why ophthalmologists who are trained in the periorbital, periocular area can't do a better job and understand the anatomy. So this is actually one of my technicians. She told me, she said, I don't need Botox. I'm fine. And now she's always asking me for more. And you can see there, we're asking her to do the exact same action in the second picture, but she's unable to. And it's relaxing that. And essentially for her, she's in her mid-30s. It's essentially her concept is not only does she want that smooth look, but she also wants to prevent those dynamic lines from becoming dramatic static lines. Sort of. I always think about the Steve Harvey line. You know, some patients bring that up to me and say, you know, can you do some Botox here? But you know, honestly, I think that at the end of the day, it's all subjective, right? So I think a lot of times when you do Botox with men don't have different considerations that they want in regards to Botox, and it's important to understand that this is why we customize these things. So energy-based devices. So this is probably my favorite part of my practice is learning about all of the lasers and the radio frequency. And this is an area of medicine that is growing very quickly and very fast as people are starting to get away from maybe the tear trough fillers and some of these things. People are starting now to gravitate towards the energy-based devices. Now, I think there are a lot of CO2 options out there. I personally use the Luminous AcuPulse, but there are a lot of other options. I'm not their brand person or spokesperson. I think that it's one that I've used a lot for. It's a laser I've used a lot for a long period of time, and I think that it's very effective and it's been pretty consistent. There are different treatments that we can do. We could do a superficial treatment. We could do a deep treatment. We can also do a combination treatment. In almost every surgical case that I do a cosmetic surgery, whether it's lower or upper lid, I'm almost always using the CO2 in some way. I'm resurfacing. I have noticed that it does speed up the recovery. Patients that get laser, their recovery is faster. I have noticed that it does improve the skin texture. So although I can remove skin in the blepharoplasty, I can't improve the skin texture just from removing the skin. So this is an option that is safe for patients, but I also think it's important who's doing it. Right? I don't like anybody just, when I always see these videos of people not using any numbing medicine for the lid, they're not using shields, I've seen people do laser at high levels that are way too high for the eyelid. So it's important to know this. So as I mentioned, mandatory eye protection is very important. I use metal corneal shields. It's pretty effective and easy to put in, comfortable for the patient. Put a little lubrication in the eye, and they're comfortable. This is a patient that we did a lower eyelid bleph on, and and a lid lift. But the big thing here that I wanted to point out was that if you look at the top photo, you can see the skin texture. And that skin texture in the bottom photo it almost looked like a filter because it was so, after post laser, the patient improved so much. But what we can do with laser, the improvement in skin texture is pretty incredible. And I always encourage patients, if they can, if they're a good candidate, to consider using a CO2 laser. This is another patient that we did. You can see she has her lids are have a reddish hue. You could see that there are some wrinkles there. We did CO2 laser. We also did IPL for the redness. We did CO2 laser, and you can see the improvement there for her as well. And so when we think about laser, we do have to be careful in certain Fitzpatrick scores. And I'm a big believer that if I'm going to offer one treatment, I also want to make sure that I understand treatments that can be used to treat all skin types. And so the Ultra Clear is a new laser that's becoming very popular, and we consider that a cold laser. The reason why we consider it a cold laser as opposed to CO2 is because the heat doesn't stay in the tissues for very long. So when you apply it, the heat almost instantly vaporizes and it's gone. Whereas with the CO2, that heat can sort of linger, and that's what that heat is. It helps with eventually that disruption of tissues and stimulating collagen. But that same heat is what irritates pigmented individuals. Whereas the ultra clear laser, because of this fact, the ultra clear laser is something that we're now seeing a lot of oculoplastic surgeons and non-oculoplastic surgeons, honestly, starting to use this particular laser. So patients might ask you about this. This is sort of in kind of another tier of when you're getting to the place where you're considering energy-based devices. Patients love this, and the more people you can treat with it, the fact that it gets great results as well, it's a good option. I still like CO2 for certain things, but I do think that it's important to have something that's effective that can treat everyone. And you know, the downtime, 1 to 2 days, right? Someone can come in on their lunch break. It doesn't hurt, you know, if you're doing sort of a 3D miracle or you're doing a lower level setting. Someone can come in 1 to 2 days. Their downtime's a lot lower, so that's something also to consider. As far as radio frequency, this is important because it does involve, when we think about ophthalmology, it's important to counsel patients on radio frequency and radio frequency microneedling. Radio frequency essentially is this concept of heat helping to, you know, applying some heat to help stimulate, you know, collagen. Microneedling is causing a little bit of punctures and some damage to stimulate healing and also stimulate collagen. Now, they found when you combine the two, you get radio frequency microneedling. And so you have these the puncture sites. You can go deeper with the RF, and it can apply that heat at deeper levels. And so when this came out, so we know devices like Morpheus are important in this role. Now, when we think about the lid thickness, we talked about this before, we want to be very careful with Morpheus, right, around the lid if people aren't understanding what this can do. 0.25 to about 0.5 millimeters is essentially more or less a depth that we want to consider. Why are we concerned about this? It's because of the orbital fat. So if in some patients that had Morpheus and they didn't have now Morpheus has a different tip that they recommend now, but before, in a lot of med spas, people will just pass Morpheus or they'll do radiofrequency microneedling along the lid. But what we started to find was there was some fat atrophy that would occur. And there's no way you can control that, right? That's not something that can be easily, once you start to apply the technology, it's hard to predict what's going to happen with that particular patient. And so this is why we've started saying to people out there in med spas or people out there who are using this to be careful and to essentially use the tip that Morpheus has promoted to sort of tackle this issue. Now, we talked about the thin lid skin. We talked about the depth that we want to go. And we talked about having, you can go into it. Once you get deeper into it, we start getting to RF, the energy for the radio frequency. But it's important to understand that the big thing to counsel patients on is that fat atrophy and how that technology, as great as it was promoted for a long time and pushed, everyone was talking about it. But again, as ophthalmologists, we have to think about how is it affecting the lids. Now, we kind of went over some of these things a little bit earlier. This is something that's good to know. But radio frequency for dry eyes. So this is something that has come up even in my practice at Arizona Eye Specialists. We have been busy with IPL, and it's interesting. Sometimes we buy these devices. When I was in Virginia, I was practicing in Virginia Beach, and they had bought an IPL, and they never used it. And so when I started my practice, we had a procedure room. We started using the CO2, and we were busy with the CO2, so they figured, hey, let's buy the IPL again. Let's see if it's going to work in terms of marketing to patients. And then by dedicating a space to it, by telling patients about it, by promoting it, 4 or 5 doctors were busy with IPL, just cash, no insurance. And I think a technology, it's when it comes to aesthetics, it's not like functional where patients just come to you just because they're referred to you, or perhaps maybe they found you and they have a medical need. You have to talk to your patients about it. And a lot of times, if you can convert your functional patient to a cosmetic patient or to a patient, and especially a patient that already needs dry eye treatment, right? If you can convert some of these patients just by talking to them, hey, we have this option, And some patients, you'll be surprised. I'm always surprised at the patients that say, yeah, I'll do it. When do we start? And so IPL has been an important part of ophthalmology, FDA approved for treating dry eyes. We know that it can affect the Demodex. It can also treat the inflammation. It can treat some of the vascularity that we can see on the lids. So there are a lot of benefits to using IPL, but the limitation that we run into is, as I mentioned, are for those higher Fitzpatrick scores. And how do we treat their meibomian gland dysfunction without necessarily using the energy that IPL does? So intense pulse light therapy targets pigment in blood. So we need something that's going to be different. So non-invasive bipolar radiofrequency therapy doesn't use any needles. And essentially you have a small handheld applicator, and you're delivering controlled heat to the upper and lower lids, and then the heat treats the meibomian glands. And so at the same time, you also have this cosmetic, indirect cosmetic side effect just with the treatment of the RF. And it's important to know that IPL we have BBL, which is another generation of what the IPL is. A BBL is a laser that broadband light therapy. It's more so if you're going to do full face rejuvenation. There are certain benefits to that. But I think for the ophthalmologist, IPL is still a key entry point into bridging and incorporating aesthetics into your practice. I think because not only does it include the dry eye component, we introduced that to our practice recently, and again, same thing. They had the IPL sitting in one of our offices. It was just there. People gave up on it. They said, okay, well, we're not really using it. We can't get patients to do it. But the problem is the doctors aren't talking to the patients about it. No one's promoting it. No one's talking about it. And so we started, we got busy my practice got busy with CO2. We got busy with some other devices. And then we started saying, hey, let's use IPL. We got our MDs involved, and now we have doctors using the IPL machine all of the time. And so I think if you introduce radiofrequency, RF, you would have a bigger pool to treat from, and you would be able to essentially treat the glands and have an effective treatment, and it gives you just more options, and it's something to consider. Former Eye by InMode is a device that's used for that, for RF. Now, the last module we're going to talk about are biologics and skincare. So this is an area that there are a lot of trending topics in here, and you may hear about them, you may see them. And again, as ophthalmologists, we should have an opinion on these things because we are responsible for their eye care. When it comes to biologics, you may hear about PRP, you may hear about PRF. This is something, again, that's been there, but now it's starting to come back again. It's starting to trend again. And PRP, platelet-rich plasma, PRF, platelet-rich fibrin. So what we do is we draw blood, and then when we spin it with coagulation, and we spin it really fast, then we get platelet-rich plasma, right, in this context. When we start to spin it slower, and we don't use anticoagulation, we get the platelet-rich fibrin. So the idea is now we're keeping some of the stem cells, we're keeping some of the white cells, we're keeping some more stuff in the blood. If we can take the albumin, heat it, and cool it, we can use that as an easy gel. And that can kind of give a biofiller type of effect where you can sort of treat the hollowing. And the idea is that PRF is that second generation after PRP. The idea is that you're stimulating growth factors, so it requires a lot of treatments. Some people say that there are variable results because you can imagine drawing the blood of a 70-year-old sedentary person is very different than drawing the blood of a 25-year-old cross-country runner, right? So they're going to be very different patient profiles, and so because of that, there could be variability. Also, it's important to note that these are not going to treat. They're not going to treat under eye, fat prolapse, and so patients they do everything they can to avoid the bleph, and at times we just have to educate them that hey, this is not going to help. What does it help? What can it be effective in? It can help with sort of promoting the lid health, the skin, patients who have really thin skin, that may want some treatment, some improvement in their skin texture. It stimulates certain growth factors that can be helpful. But then again, it requires a lot of treatments to have the effect. This is a photo showing the difference. You can see that with PRF, we have different content that's there versus PRP. And so if patients ask what's better for them, if they're going to get it, PRF is going to be a better option. Now, there's something called, that's out there that's important to know, platelet-derived growth factor, PDGF. This is something that's becoming popular now. This is apparently significantly more potent and stronger than PRF, and it's not yet FDA approved for injection in the under eye, but a lot of patients are getting it. And I think it's important to know, I think about when there are new things like that and something that's that strong, my concern is, it's been used before in medicine, but around the lid, I always think about, is this something that can cause growth of cells that we don't want? So that's something to think about. There's still a lot of research that's being done with that, but it's important to know and to be aware of the different options that exist. So in terms of eye creams, evidence-based eye creams, I always tell patients most of the time your eye cream is not working. But in terms of eye creams, we have to think about it from the perspective of skin, right? So if you have skin there, can you treat that skin? What can we do for at least the skin portion of it? And so if they're going to use it, what are ingredients that they should know about? So vitamin C, this has been sort of the gold standard in terms of skincare. Vitamin C is great for brightening. We know that it plays a role in healing in general. Caffeine, products that have caffeine are good for that early morning puffiness or edema that patients may get. Peptides are my favorite ingredient. Peptides are very safe, and they promote improvement of the texture over time. And niacinamide is also something that patients may find helpful. Now, when it comes to retinols, this is sort of a controversial topic because some people talk about it, some people don't talk about it. And essentially, there's this thought that perhaps retinols can play a role in terms of affecting, the oil glands. And so usually when I tell patients about using retinols, I usually tell them to keep it a certain distance from the lash line, just kind of right below, the orbital rim, some kind of stay in that area. Some people don't really think a lot about it, but I think for us it's a particularly sensitive topic because we're trying to promote meibomian gland health, and so I always tell patients to just be careful, especially if they're over applying retinols in the lower lid area. And so something to know about too is patients may ask about hollowing. So these hollowing is coming up a lot these days, and patients are asking about that. And what's an alternative to filler? What's an alternative to that could be fat grafting. So if you're aware about fat grafting, we're able to take fat from basically the inner thigh, sometimes the belly. We can take the fat and we can use that to transfer to the face. Sometimes we combine it often when we're doing a lower eyelid blepharoplasty. But it is an option that patients can know about. The issues with fat is that fat can, you may inject a certain amount of fat there, and then there's a lot of that fat may go away. Some patients, you may inject too much fat, assuming that that fat is going to go down, and that fat doesn't. So there are some risks to that too. And even though you may not get into that side of things, it's good to know that that's an option for patients that a lot of oculoplastic surgeons are getting into. Some of us are still doing other things like fat repositioning and other options for patients. And so, as far as in conclusion, I think understanding aesthetics as a general ophthalmologist, as a generalist, is really important. There are going to be a lot of questions patients are going to ask you. We didn't touch on eye color change surgery, but that's something that a lot of people are now starting to ask about, think about, and I've definitely seen complications from that. And so I think that going into aesthetics and doing it in a safe way, I think starting off with neuromodulators, starting off with IPL, RF, I think that's an easy start, something to introduce to your practice. I would encourage the doctors in the practice to talk about it, to tell patients about it, and focus on converting the functional to the cosmetic. That's going to be really important. I found that helps start a very successful cosmetic practice. There's also going to be a need for some branding and patient education. Why should they have an IPL, right? Why should they have an radio frequency treatment? Why should they, neuromodulators? They might say, "Hey, doc, I feel there's something going on here." Well, we can take care of that for you. As far as scaling up, you're going to think about the CO2 laser. You might think about introducing filler in a safe manner. You might think about things like ultra clear. If you're getting really bold, you can start to think about the biologics at some point, PRF with Easy Gel, and look at those things. And then you can, I think everyone can focus on a skincare strategy, even if you don't have skincare in your practice. I find for me, when I first started, we used to have a lot of skincare products, and I've just whittled them down to just a few that we're going to sell all the time. And I think that's the way cosmetic and aesthetics works. It's like, what do you do in your practice, and what can you offer all the time? What can you talk about? Just comes, you can introduce that. If you have too many things going on, it's you're wasting money, and it's going to be hard to keep up. And so it's important to understand skincare, important to understand what to recommend to patients regarding their skincare. And so that's it for now. Thank you for letting me present to you guys about this. And if you have any questions, feel free to ask. Yeah, that's a great question. So xanthelasma. So we know that sometimes there's this teaching of when you excise a xanthelasma, it can come back and even be worse than it was before. What I've started doing is I've actually combined xanthelasma treatment with laser. So I actually laser xanthelasmas if they're small, or if they're essentially if they're large. Laser has been pretty effective. I found a lot of success in my practice in treating with laser. You can excise if they're small lesions, but you just have to let them know that, hey, these, it could come back. And so that's kind of how I've dealt with it. Prior, it used to just be excision. We'd run it through insurance and say it's a lesion, but now it's not. We don't do it through insurance. We just say, hey, if you want us to treat that xanthelasma, we can do laser, and it's been pretty effective. It's worked pretty well.
What laser is that?
The CO2. Yeah. Yeah, that's a good question. So for the first question, I think with the IPL, I have not seen lash loss. We don't get we say a couple millimeters from the lid margin in the lash line, and we haven't seen lash loss yet. I think it also depends on we try not to apply the IPL directly over the margin, because part of it will it'll kind of overlap. And so if you just stay just several millimeters above, you should be safe. It should be fine. And we found good success with that. In terms of billing insurance, I think the hard thing with when patients come in for chalasia, it's hard because they don't always come in that acute time frame that it's said that you can treat with that. And so I think that in terms of billing can get kind of tricky with IPL if you're going to use it. And so we haven't billed. Typically if a patient comes in and they want the IPL, we charge them for it. So because it's outside of our IND and our if we're going to do a drainage. So we just say, hey, if you want it to be done with the IPL, and I haven't really treated I haven't really used the IPL because by the time they get to me, they're already they've had it for 2 or 3 months, and so it's a little different. Yeah. All right, awesome. Thank you.